Yes.
يلا 1 2 3. Go ahead, Doctor.
All right. Good morning, everyone. Welcome to the 5th Antimicrobial Stewardship Symposium or course. Today we're going to be going through a program about antimicrobial stewardship in general and how we can try to find ways to apply it in our hospitals and different settings. Just some housekeeping points. There will be 3 CME associated with this course. Please make sure to put your questions in the question and answer part, and there will be a question and answer sessions after each group of presentations. And there will be a pre-webinar quiz shared with you at some point. So now I would just like to take the chance to welcome Dr. Majid Shamrani, who is our Executive Director of Infection Prevention and Control at King Abdulaziz Medical City here in Riyadh and for all National Guards. So Dr. Majid will be presenting about the impact of antimicrobial resistance on healthcare resources and outcomes. And the floor is yours, Dr. Majid.
Thank you, Noor. Thank you very much. It's truly a pleasure, to arrange this, week, and I thank you a lot, Noor, for, help and put this all together this week. We are just, with international organizations and bodies, we are celebrating, the Antimicrobial Awareness Week. A lot of activities going on, and this one is one part of it. And I'm sure it will be very fruitful for everybody. I will try to share my desktop. Let me know if things are okay, huh? Is it okay? I cannot hear you.
Yes, Doctor.
It's fine, huh? Okay, good.
Yes.
So my talk will be about the impact of antimicrobial resistance on healthcare resources and outcomes. And generally speaking, I just want you to. Why is it moving? Is it moving at your side? Okay. Generally speaking, if you, I'm telling you that there is an airplane which is, Boeing size 777 or 777, falling down on daily basis in the United States, and around 400 people killed on a daily basis. This will make a lot of chaos, and people start, what is this? This is a problem, and nobody is looking at it. But truly, the number of people killed by antimicrobial resistant in daily basis in the United States, it almost equal to this number, and they are dying in daily basis, and nobody looking at it. And this is only United States. But if you want to put it in international, kind of, numbers, this will be huge. And that's why we start asking ourselves: is AMR, antimicrobial resistance, the public health crisis? Can we consider it a public health concern, or just hospital-based issues, country-based issues, regional-based issues? But it's not a concern reached to the public health level. And this is something that we want to discuss, because the impact on resources, impact on life is huge, and also to the hospital and individuals. And how we can look at it from successful response point of view, and then how to implement a successful strategy to address the AMR. I will not go in depth in that, because our colleague, they will talk over the day or the rest of the course, looking to the strategies and how we can build from leadership till implementing to end user a good effective program. So based on what I said from my introduction, to us, we have to consider AMR as a public health concern. Public health concerns mean like COVID-19, like Ebola, like all kind of emergency diseases that we are afraid of, and we start fighting, talking in the media and everywhere about it, because it's a difficult and dangerous situations, because it's reached to the critical phase, and because we reach to the point and a time which is a very crucial time and we are actually in a mending crisis. Our hospitals, they are full of, multi-resistant organism. Our death on daily basis, something that we are not measured and linked directly to AMR, but it's there, and in its daily basis there, but unfortunately we are looking at it. So if we look to this, contest of criteria, the three one that I put, antimicrobial resistance reached to that point, and that level of issues. I usually like this, two slides, this one and the other one, and it actually tells, how is mortality decreased over years, and what are the major impacts when it looks to USA data when it comes to infectious diseases, and what are the things help a lot to maintain low level of infectious disease among people and low level of death due to infectious diseases. The first most important part, it's to have a public health department. So we are looking to everything from human, factors, as it's a public health issues, and try act on it in a structured way. So they're building just people around and think about it in a department in the United States. This makes things going down. So here we have a 40.
Dr. Majid?
Yes. Yes.
Sorry to interrupt you, but I'm not sure, but I don't see your slides moving.
I will just maybe stick to this, slide till Noor come here and help me. She's in beside, office. But generally speaking, this very important, graph, and I just maybe simplify it in a way by description. It's having a public health department is very important to control infectious diseases. After that, having vaccine, chlorations of water, and the antibiotics itself. So these are very important factors to help. Noor is helping me here now. To help in having, controlling of infectious diseases. As you know, that penicillin was first discovered in 1928. At that time, it was not commercially used, and started commercially to be used during the 40s. And the 40s, as you know, it was the World War II. And when you compare World War II with World War I, wound infections decreased a lot because the discovery of penicillin that was used at that time, to the point that it was used in recruitment kind of advertising. I don't know if it's working or not. Hopefully it's working now. So started using it in war like advertising for recruitment, that if we have penicillin, things will be okay and people, they can come safely home. But truly, if you look back, just like almost from 48 we're talking till now we are 2020, with almost like 70 years, penicillin is not working anymore, and people, they die due to penicillin resistant organism hugely, and this is causing a huge impact, and it's not anymore something that we can put it in a poster like this one, which is distributed during the 40s. Thanks for penicillin, he will come home again, and then this is not something valid anymore. And part of what we have when it comes to development of new antibiotics, whenever we have a new antibiotic, for a while bacteria, they are very smart and start to build their resistant capacity in a way that after a few years, several years, 5 to 10 years, we start to see emerging resistant to these antibiotics. Whenever we have resistance to antibiotic, most of the time it's a class effect. So it wipe maybe all or almost all antibiotic in that class. So whenever we have penicillin problem, most likely it will extend to other type of antibiotics, cephalosporin and others. And whenever we have one of aminoglycoside, it will go to the others. So generally speaking, 5 to 10 years afterward, and the antibiotics start to have a problem, and it's not working anymore at most of or on some of occasions. We have to keep up by producing more antibiotic, but this is a problem because producing a new antimicrobial or new antibiotics, it will cost a lot of money, and it's not something easy. And if you look to the last 20 years, it's very few number of new class of antimicrobial being discovered. Noor, is it okay that from can you see my slides now or it's not? I don't know if you can see my slide or not. To that, WHO starts putting some of categorization of the problem and try to measure the problem. And just in close kind of glance, and this is actually from, I believe, from 2017, 2014, 2017, and now we are looking to the number of resistant organisms that affect community-acquired infections. We're not talking about healthcare-associated infections a lot. It causes healthcare-associated infections and community-acquired infections. As you know, WHO, they have 6 regions, and we are looking here to E. coli, Klebsiella, and Staph aureus. So this is the graph I was talking about. I'll try just to wrap up. I'm sorry about this all. So this is the graph I was talking about before, about the public health departments, curations of water, then having the influenza vaccine, and then afterward having the antibiotics, and this how things with infectious diseases and mortality due to infectious disease decreased. Looking at it from public health perspective, it's the most important part, and this is why we need to look at the AMR. And this is maybe the poster that I'm trying to describe, but it was not there. And this is in World War II, where we are seeing penicillin doing all the job and a good job, and people they can come home safely. But this is not anymore, as I said, because the resistance of antimicrobial. And here also, when I'm trying to describe before that, whenever we have a new antibiotics, just 5 to 10 years after, resistant will emerge. And here, starting with this arrow, it means we're developing a new antibiotic. Ending with this arrow with a green top, it means that we start to have resistance. And you can look to all classes. And unfortunately, as I said, in the last 20 years, the number of new classes, the number of novel kind of antimicrobial, it's not there anymore because the cost that's associated with developing a new antimicrobial. And here we are saying that we have 6 WHO regions, and we start seeing in the 6 WHO regions the emergence of community-acquired. I'm not talking about hospital-acquired or healthcare-related acquired. We start to see resistant organism in people coming from the community, from home, with the resistant bug. Before we were seeing people with resistant bugs emerging from the hospital, but now actually we're looking at them coming from home. And here we have 3 organisms: E. coli, Klebsiella pneumoniae, and Staph aureus. If you look to the E. coli, 3rd generation cephalosporin resistant in 5 out of 6, all except Americas. And here we can find them almost 5 out of 6, as I said. Fluoroquinolones 5 out of 6 WHO regions, all except Europe. And for Klebsiella pneumoniae, actually 3rd generation cephalosporin at 6 of 6 all regions, and WHO regions all over the world, we can find that Klebsiella pneumoniae, that 3rd generation cephalosporin resistant. And it comes to carbapenems, 2 out of 6 regions like Europe and Eastern Mediterranean, they are a little bit, safe, but all over, sorry, it's 2 Europe and Eastern Mediterranean, our regions, they have it more common than the other regions. And for Staph aureus, for MRSA, 5 of 6 regions, the problem with MRSA is there. So all 6 WHO regions which is covering all over the world, actually they have an issues and problems with resistance, and that's why they put these kind most common organism under a microscope and start looking at them carefully and warning people about them. And not only that, the WHO looking to this more carefully and put them into categories where we have critical, high, and medium. And as you can see, this is our bacteria that we're seeing every day in our hospitals. So the critical one, the Acinetobacter pseudomonas and Enterobacteriaceae, and actually our hospital here in the region, in the Kingdom of Saudi Arabia, and my hospital, Najjar hospitals, we have an issues where we have emergence of this kind of cluster of cases with the resistant bug of critical value. And this what will lead, and we are looking here mainly to hospital-acquired infections and this is maybe my topic where we're talking about the impact of these infections on resources and also on life. And here we can easily look just mainly to the device-associated infections like central line-associated infections, ventilator-associated pneumonia, surgical site infection, and also C. diff, which is Clostridium difficile infection, and UTI. And this will cost in the United States, annual data, 9.8 billion, and it's a huge amount of money that we waste in our system. Unfortunately, from the regions, we don't have a cost, analysis for hospital-acquired infection. But if you compare ourselves with the United States, we almost have the same number of problems, and 9.8 billion. It's a huge amount of money that they are losing every year for these kind of infections. And if you look to just central line infections, for every case, 45, almost $46,000 they are losing for every case, and also for the others it will be less a little bit, but the impact is huge. And now we are looking to why actually we have this number of hospital-acquired infection in critically ill patients, and the role of resistant organism leading to this outcome. The resistant antimicrobial or organism, actually what they will lead to have something called inadequate therapy. So whenever we have a patient in ICU and they are sick or severely sick, we'll put them on antibiotic. Afterward, we'll have the cultures come, and the culture tell us, the organism that we isolated from patients, it's resistant to the antibiotic started 2 days ago or 3 days ago, and this is considered inadequate therapy. And just to make it more simple, whenever we have an antibiotic started, empirically without having the culture result, and this is what we do usually, and later on we have an organism that's resistant, it means inadequate therapy. And the cause of inadequate therapy, mainly it's resistant, and this will have a huge impact on life and also on mortality. And generally speaking, we see it a lot in hospital-acquired infections rather than in community-acquired infection. The orange one is the community-acquired infection. The blue one is the hospital-acquired infection. And generally speaking, the inadequate therapy is more with the hospital-acquired infection. Why that? Because we have resistant organism. Resistant organism usually acquired more in the hospital setting, and that's why whenever a patient acquired an infection, a hospital-acquired infection in the hospital, most of the time they will have it with the resistant organism, and this will lead in inadequate therapy, and inadequate therapy will lead to more mortality. And they are here. You can just simply look to different studies all over the years, and the yellow one, it means that we give a good therapy to the patient, and the blue one, we give an antibiotic that later on it was not the appropriate antibiotic due to resistant or due to something else. And you can easily look to the mortality comparing yellow to blue. The blue, which is inadequate therapy, most likely due to resistant in some of these studies, which is already, I give you most of the organism isolated in some of them, mean that the mortality will be huge. Sometimes it's more than 50% or 100% increase in the mortality compared to inadequate to adequate therapy. And this also a study that looking to three main things: the impact on death due to this infection, which is resistant, like MRSA or VRE or Acinetobacter. So the impact of death, first one, the attributable length of stay, which will become longer, and also the cost. So the problem with death, it will impact patients, hospital, clinicians, and the problem with increased length of stay, it will have a problem on payment, because patient, they will pay more, hospital will lose more money, and when it look to the cost, actually everybody will lose, patient will lose, and hospital will lose when fighting against AMR, and we don't have a way that we can mitigate their problem. The cost will be huge. So the impact on life, the impact on length of stay, and also impact on cost, all will increase for hospital-acquired infection and antimicrobial resistance. For that, people, they start talking, they start giving stories. We start seeing this resistant organism, and and the media start going on and on. And the main media campaign and the problem and people they start looking and talking about it started almost from early 2000, but generally it continues till now. But before that, Alexander Fleming actually he told us that we will have a problem with resistance if not using antimicrobial wisely. So what are the main driving of this problem? It's using antibiotics, and using antibiotics, unjustified, overuse, abuse. You can give it different name, inappropriate, inadequate. We can give it different name. But the most driving of antimicrobial resistance is to give antibiotics. And it's not only in human. This actually will be in between human, between animals. In the agricultures, we are using antifungal. In the flowering, agricultures, and we're using antibiotic for animals, as some countries actually or farms they use it as a growth promoters, and this also costs a lot of money and costs a lot of infections. And we are changing this between animals and human all over the time, and this with our hospital, and this will go on and on. It's not only that the infection control is not a good example alone or a method alone to control infections actually or multi-resistant. If you look to this diagram, we're looking to people moving from hospital to hospital and people with infections, and it's easy, you can see that people they keep moving a lot from hospital to hospital, healthcare facility, and with the resistant organisms. So infection control alone is not the answer. And many countries they start looking to things more seriously recently, and they're putting some like action plans, and they're putting reports and sharing ideas and sharing just to decrease the impact, and looking how to exchange experiences among countries and also international bodies and organizations, and looking at also consumption of antimicrobial between animals and humans. So if you look to the animals and the cost of consumption antibiotic in the animals sometimes exceed. The blue one is the animal side, the human, and this will cost also a lot of money and have all devastating back draw later on. And the consumption, the conception of or the concept of One Health start to be emerged. It's not only looking to antibiotic. If you want to decrease the cost, you have to look to a lot of things, to the animal side, to sewage system and clean water, and also we look to the hospital infection control and stewardship program. And to need a lot of coordination, cooperation, communications, also need to computations of data. So a lot of work need to be done. A lot of collaborations with different bodies need to be looked carefully with the interministerial kind of between ministries, having board in the countries addressed by high level of the people in the country. This is also very important. And with that, the stewardship concepts, and maybe our colleague will talk about it a lot. I will not give time to speak about, but the stewardship concept starts to be coming more obvious and an answer to combat or mitigate the issue with the emergence of antimicrobial resistant and healthcare associated infections due to the cost, due to the mortalities and morbidity associated with disease itself. And the idea is very simple, just to justify the use of antibiotic in critical situation and try to de-escalate or go down or look to this broader antibiotic whenever we have a clear signs of improvement or clear signs of targeting a specific antimicrobial organism. And this will give us all the beautiful goals of stewardship program, which is combat the emergence of resistance, improve clinical outcomes, and control the costs. So in summary, this is very complex. The AMR, the impact on human, and also the impact on mortality and cost is huge. It needs a lot of efforts between different people and needs a lot of coordination, cooperations, communications. Infection prevention control programs should go hand by hand with the stewardship program to control or mitigate the issue with AMR and hospital-acquired infection. We need a lot of data. We need to integrate our system and information system together, and we need to build our laboratory capacity and to do a lot of evaluation and evaluate and do a lot of interventions. With that, I will say thank you very much. I'm sorry for these issues, and I think I was not saving my slides, but thank you very much all. I think that we'll leave the question and answer at the end, and I'm just finished on time, alhamdulillah. So with that, I will just maybe continue to introduce my colleague, and I'm moderating the first session. The next talk will be my colleague, Dr. Asim Saadi. Dr. Asim Saadi, he's actually he's an ID consultant. He's the Associate Executive Director of Infection Prevention Control in the Western region, in Jeddah Hospital. He has a lot of, initiatives towards stewardship program, and also building a leadership and capacity of train people, and also policies and procedures in antimicrobial stewardship. So he will give us a talk for around 20 minutes, and his talk will be about the leadership in antimicrobial stewardship. So Dr. Asim Saadi, تفضل.
Assalamu alaikum. Thank you, Dr. Majid. I'm trying to share my slides. You already unshared your slide, Dr. Majid, yes?
Yes, I did.
Okay, because the shared tray does not show up here for me.
And I'm not like usual. Today I think there is an issue with the team or that.
Dr. Asim, can you share your slide, please?
The shared tray does not open up. I'm trying to share it, but for one reason or another, it doesn't showing up. So I'm pressing with the open share tray, but the choices don't show as usual. Okay. Let me try to do it again here.
So to my colleagues, while Dr. Asim is sitting his, stage, I'll just maybe try to give some hint and examples how we should look to the problem with AMR and how we should respond. I don't know, maybe we're from different hospitals. Some of my colleagues maybe in my hospital here or National Guard Hospital, but truly people who's interested in or the team that should, look and try to put something inside the hospital to combat the AMR, the ID physicians, the clinical pharmacists, the microbiologists, the also the nurses, rule, and maybe one of my colleagues will talk about it later on today. All of these need to put together, and we have some platform where we can talk about how we can build in the hospital a system that will address, the concern of AMR by data. So it has to be a data-driven action. So we have number of antimicrobial consumption in our hospital. We have number of MDRO or AMR in our hospitals, and where we are, in comparing to other hospitals, and how we can move on. How we can move on by establishing stewardship program, by sharing experience, educate people, building policy and procedures. All of these kind of things, they are very important. Most importantly also is how to, with all, national transformation from digitalizations and making things easy by computed, data. And we need to look to our system and like the patient electronic system that we have in the hospital, and try to see how we can improve it in a way that can detect and help and produce some, information towards, stewardship program, and how we consume the antimicrobials. Dr. Asim, are you still trying? Dr. Asim?
Yes. He will try again. Just a few minutes, inshallah.
And I want to just use also questions and the chat if you want to write anything, so we can also answer if you have any questions. And Later on, whenever we build this capacity inside the hospitals, inside our lab, from testing, how we go a little bit over to cooperate with other hospitals around us, either from sharing data or from the regions, and then with the national, like the Saudi CDC and MOH, where they have all the policy and procedure and communications from surveillance system, and connect all the dots together. This is from the health parts. When you go outside the health part, like the animal side of, and the sewage system, clean water, pharmaceutical care, and outside, MOH and, hospital, all of this need all of governance, control. It has to come from the country, and that's why countries, they need to build their action plan. And it's more than us, if you want the truth, but at least our colleague now with us, physicians, nurses, and microbiologists, clinical pharmacists, please work together in your hospital, try to look to an answer how to combat the AMR. Infection control will be part of your, also team, and the most important part of the infection control to optimize infection control policy and procedures and practices. Most important part of infection control to answer programs to answer the AMR is hand hygiene and environmental cleaning and disinfection. So hand hygiene program in your hospital is very important, and how to help and optimize the compliance with the 5 moments of hand hygiene all over the hospital is very important. Regarding the environmental cleaning and disinfection, it's a problem in most of our hospital. Auditing, according to CDC audit tool for cleaning and disinfection, also it's a part that you need to look at. So nurses need to audit the housekeepers, infection control practitioners need to audit housekeepers. They need to know that they are using the right detergents. They need to know that they are using the right materials from cloth and mops and others, and most importantly, the right practice when it comes how to clean the room and how to concentrate in high touchable or frequent touchable area in the hospital or in the room.
Dr. Majid?
Yes.
I wonder, I don't know about Dr. Asim, but do you think we should switch the presentations for now?
I think so. I'm about to say it, if you want the truth.
Okay.
So Dr. Asim will just give you more time. Maybe Noor, she can start now. If you're okay with that?
Yeah, absolutely. Yeah.
And Asim, you're okay? He's not around?
No, he's not.
Oh, okay. So let's just switch the talks. We'll start with Dr. Noor, and then we'll go to Asim after. So Dr. Noor Champs is our clinical pharmacist here in Riyadh. She's ID clinical pharmacist. She has, in her capacity, observe and run stewardship program and also build stewardship program. She has a lot of initiatives toward establishing sustainable stewardship program through patient electronic system, and she will give us a talk for 20 minutes or 30 minutes about the antimicrobial stewardship overview and also the Ministry of National Guard Health Affairs activities. So Dr. Noor, go ahead, please.
Thank you, Dr. Majid. So I just want to make sure, because of all the technical, can you see my slides?
Yes.
All right, excellent. So, all right, so we're going to go through a general overview of what antimicrobial stewardship is and talk a bit about National Guard activities so that we can share with you some practical ways of what we have been able to do and how very simple, low-hanging fruit activities can be done. So the objectives of this presentation is to define stewardship and stewardship programs, to understand the rationale behind antimicrobial stewardship. And Dr. Majid gave a very thorough overview of antimicrobial resistance and how resistance has very impactful outcomes on patients in a negative way, of course. We're also going to discuss elements of National Guard activities in ASP. So stewardship is a word that basically describes the careful and responsible management of something entrusted to one's care. So if you think of stewardship of natural resources as is in line right now with the 2030 vision of stewardship of water, electricity, trying to not just save money in order to save money and keep it on the side, but be able to use resources and money in the best way possible to improve outcome of living and healthcare. So in the similar way, we can talk about stewardship of antimicrobials. So my favorite example about stewardship, which is basically a parallel example, is when you get your salary at the beginning of the month, and you have to decide what percentage of your salary are you going to use for your living expenses, for your saving, for your future plans. And your salary is finite. It will diminish with time and unless you replenish it. So this is why it's very important to take care of how you utilize your salary. And in parallel, we can think of the same thing with antimicrobials. Of course, there is a specific emphasis on antimicrobial stewardship, but in parallel, you can talk about stewardship of also hospital resources. For example, how many masks are you going to buy this month, or how much metformin did you prescribe and dispense? So, but there's a specific important aspect of antimicrobial stewardship, which is the fact that in our bodies we have 10 microbes for each one cell. So if you think of it that way, we have around 2 kilograms of our body weight is microbes, which includes bacteria, fungi, and viruses. So in a sense, when we think about impacting taking an antibiotic for an abscess, let's say a tooth abscess, of course you're treating the abscess, but you're also impacting a big amount of your microbiome, which also has a big impact on your immune system, on many different things. So this takes us to the idea of pathogenic versus non-pathogenic versus symbiotic bacteria, and why it's important to differentiate or identify that even if you're treating harmful bacteria, you will also impact the symbiotic bacteria and the other bacteria or fungi or viruses, the ecosystem in your body that is responsible for a lot of functions, such as the immune system, like I mentioned, providing nutrients for our cells, and preventing colonization by harmful bacteria and viruses. You can see here a very famous and known slide from 2007, which described the antibiotic deployment as well as the antibiotic resistance development. So you can see here, if you can, I think, see my, I'm not sure if you can see my mouse here, but penicillin was developed in around 1940s, and within the same couple of years, they were able to define and identify the first resistant penicillin strain. Of course, there's another major part of inappropriate use of any medication, in addition to antimicrobials, which is unwanted effects or adverse events. And it was noticed that antibiotics are the most common cause of adverse events in children, leading to ER admission. So not only are you impacting your body in many ways, but you're also increasing the risk of adverse reactions. Another very interesting, very recurrent observation is that 1 of every 2 antimicrobial prescriptions in the outpatient setting may be inappropriate. So if you think of that, again, 1 of every 2 antimicrobial prescriptions is inappropriate. So that's quite a lot. Going back to our microbiome and facilitating the selection of pathogenic organisms, antimicrobial abuse and overuse, or even normal use, can also lead to a selection of organisms such as C. diff, which we know has high morbidity and mortality. So these are just some of the concerns of antibiotic use and why stewardship is important. And the question is, all right, how are we doing on with antimicrobial use and stewardship in our region? This is one study from 2011, which just looked at the propensity or the ability of pharmacies to or the the ability of pharmacies to dispense antibiotics without a prescription. And they had undercover investigators with signs and symptoms of clinical illness, either upper respiratory tract or UTI in women. And they found that 77% of pharmacies prescribed an antibiotic with no prescription, 95 of which had no patient request, which debunks the myth which says that patients always ask for antibiotics. None of the pharmacists asked about allergy, and none asked about pregnancy in the pregnant women. So this is a big concern, and this brings us to the next important part of stewardship. We can talk as much as we want about our personal efforts, but as long as there are no systematic approach to antimicrobial stewardship, it will be very difficult to succeed. And this is why the Joint Commission has standards on stewardship within the accreditation standards now, and so does Sabahi. The Ministry of Health in Saudi Arabia has recommendations on stewardship which evolve constantly, and so does, of course, international recommendations, as Dr. Majid mentioned earlier. There's a really nice review also about how in the Gulf region, there's a clear recommendation of what needs to be involved in stewardship on a One Health approach. So looking at awareness and understanding, surveillance and research, especially for new medications or diagnostic tools, sanitation, and of course, Objective 4 is optimizing the use of antimicrobial medicines in not only humans, but animal health, investing in new medicines and diagnostic tools, as well as vaccines and other interventions that may come along, if you've heard of phage therapy, for example. So what is the goal of antimicrobial stewardship as a program? The program itself aims to, first and foremost, to optimize clinical outcomes. So if I am restricting antibiotics, it's not because I'm reducing or worsening outcomes. I want to ensure that my patient comes in to the hospital and leaves in a better shape, basically. While minimizing the unintended consequences of antimicrobial use and reducing healthcare costs. And by costs, we're not only talking about the cost of how much money we're spending on medications, but also the cost of an MDRO, CLABSI, for example, or COUTI, or hospital-acquired infections relating to resistant infections or even sensitive infections as well, sensitive bacteria. So if you were now to put yourself in the shoes of someone who is just coming to a new hospital, who needs to set up a stewardship program, you'll find a lot of really nice references on roadmaps on how to approach the change in culture, the change in prescribing. And the first thing that you need to really consider is assessing your facility's current state. What's the antimicrobial prescribing like? What is the resistant trend like? And you really need to identify your stakeholders. So this is just an example of a roadmap that you can use. We're going to go through some of it briefly. So in assessing your baseline, you need to aggregate antibiotic use and patterns of use, perhaps through pharmacy data, rates of resistance of common pathogens, common clinical infectious disease syndrome. So you can define, let's say if your team is really small and you'd like to start, you can start working on treatment of asymptomatic bacteriuria, for example. This could be baseline data that identifies for you on the long run how good your team is at managing antimicrobial use. Antibiogram, of course, development, and of course the IT structure, which defines how ready you are to implement new systematic changes in your electronic order system. Another way to do it is just to have a point prevalence survey. So this is an example of a 12 children's hospital point prevalence survey done in 2013. There are many examples, but this was a nice one because they just did, of course, you can do it over a week, over a month, but due to resources, you can choose to do it over one day. And in this survey, they found that around 54% of patients in the pediatric ICU were on more than one antibiotic. So this defines for you where you have a high turnover of antibiotic use. They found that around 50% of patients in the surgery had more or equal to one inappropriate antibiotic. So this, of course, defines that surgery needs to be, in this situation, highlighted and included into the program heavily so that you can improve this inappropriate antibiotic use. They also found that respiratory tract infections were the most common indication for antimicrobial use. Fluoroquinolones were used inappropriately more than any other drugs. And thankfully, ID consultations increase appropriate antimicrobial use. So in general, this just gives you highlights for the facility where to start in case it's not clear. You can also use CDC checklists, which is basically a gap analysis of what you have and what you need to implement. You can disagree or agree with the recommendations, but at least you know what some of the standards are. And I think one of the most important, crucial parts of implementing any stewardship or any program which aims to change a culture of any kind within a facility is to identify your stakeholders. Who are the people who are most excited about change? Who are the people who are least excited about change that you need to bring, get along and get their buy-in, and try to find ways to include everybody from different departments, microbiology, of course, pharmacy, the physicians, quality, nurses are really important workforce that are underutilized. Infection control practitioners, IT is one of the most important as well within any system, but it doesn't mean that if you don't have a good IT electronic order system, you can't implement stewardship. And of course, hospital epidemiologists or statisticians. So once you build your team and your resources, you can start selecting your interventions. You select your interventions based on their impact and the political expediency, how easy it is to implement, and the resources required. So for example, if you if you want to decide between pre-authorization or prospective audit with feedback, or interventions designed to reduce use of antibiotics with a high risk for C. diff. You can look at interventions to reduce the shortest effective duration, pharmacokinetic monitoring with dose adjustment. This is really low-hanging fruit, which is vancomycin and aminoglycoside and voriconazole monitoring, IV to PO switch, and these are really important interventions that are proven to have a good outcome. Alternatively, you can try to think about, right, should I start with prospective audit and feedback, or should I work on restriction? So there's always this debate, which one do we start with? Of course, prospective audit and feedback requires a lot of interdisciplinary work. It needs to be trigger-based somehow. You need to decide, am I going to evaluate all patients on meropenem in the ICU? Am I going to evaluate all patients on meropenem and vanco in all wards, for example, or am I going to look at candidemia? You can decide whatever you think is important for your team, or you can also approach systematic stewardship through restriction or prior approval, which requires justification for prescription of certain medications. The evidence shows that one without the other will not have sustained impact, which means if you choose to start with prospective audit and feedback, that's great. You can get your team to trust you and move towards restriction in the future. If you use restriction alone, without prospective audit and feedback, it seems that your impact will drop after 3 years, according to some studies. So I think our humble experience here shows that both need to go along slowly and in a systematic, step-by-step way. So it's also important to note that there are some strategies that have a weak recommendation, but that doesn't mean that they are not primary. So didactic, education is important, but it will not have any huge impact unless you have systematic change in the workflow of prescribing antibiotics. You can work on facility-specific clinical guidelines, but that won't help unless people actually read them and implement them. Computerized clinical decision support systems. Cyclic antibiotic selection was proven to have not very useful outcomes in stewardship, and allergy assessment for beta-lactam allergy, which may not have it may not be as easy to start with. Of course, it's really important also to measure effectiveness of your program. So you could choose the indicators that you think are most important for you. For us here, we work on evaluating MDRO and MRSA and VRE rates, as well as C. diff. We also look at DDD, DOT consumption, which basically antimicrobial consumption through defined daily dose and days of therapy, which are just indicators, regardless of what they mean, but they basically tell you how much antibiotic consumption is happening. Cost, is of course very important. And there are certain process measures that you need to look at. So how good or how receptive are the teams to your prospective audit and feedback or your restriction recommendation? So these are some measures that you could choose to evaluate. There are many other metrics out there as well. So now to the practical part of what we have. Some of the activities have been over at National Guard. Of course, I won't be going through everything. Of course, we worked on building policies and procedures, education, building electronic reports and processes, surgical prophylaxis improvement project, which happened to be, so at the beginning when we wanted to implement restriction and prospective audit, it needed some time. So we chose to also start with some low-hanging fruit that clearly had a good outcome if it were to be implemented in the best way possible. Prospective audit and feedback, and our last step here was antimicrobial restriction. You can argue whether this is the best way or not, but this is what we did, and it's worked for us so far. We have our own administrative policy and procedure on antimicrobial stewardship that defines people's roles and activities. We have committees in different regions that require different members from different departments to join. We have educational activities scheduled yearly and weekly and monthly, focusing on different healthcare practitioners. So when discussing the surgical prophylaxis improvement project, I would like to just go through it in a bit more detail. So what we did was, while we were preparing policies and procedures and getting people on board and getting buy-in, we started working on something that was easy for us to work on. So we looked at the facility guidelines. There were clear antimicrobial prophylaxis guidelines. We looked at, but there was no audit. So we evaluated the guidelines with our team, the surgery clinical pharmacist, as well as surgeons, ID clinical pharmacists, ID physicians, nurses, and quality specialists. And we started an audit. We identified some areas for improvement. So I'm going to share with you some data here. You can see here in September 2017, we had on average 56% of our prophylaxis doses were appropriate. And with intervention, slowly it improved. So we did a lot of education, and this is by we, it's not the antimicrobial stewardship program alone. It's stewardship program bringing in people who were interested, who had time and interest in this project. So for example, Dr. Bassam Ghanem did a lot of this work in Jeddah. Clinical pharmacist evaluation of dose. So he led that project with them to improve dosing from the clinical pharmacy side as well as the pharmacy order verification part. And then improved nicely till September 2019. Of course, there's data past that. That is not yet in the slide. As for timing of administration, which some of you may know that it needs antibiotic surgical prophylaxis needs to be given before 60 minutes for most antibiotics before skin incision. You see here in September 2017, it was also around 50% appropriateness, and it went up in January 2019 to 86%. However, unfortunately, it dropped in February 2019. Now, the reason for that was we reduced our feedback, and we were able to identify that this improvement was due to personal effort rather than a workflow change. And this is what led us to the next step, which is to implement in PestCare, which is our electronic order system, which is currently ongoing, this change, a workflow change that requires documentation as part of the normal workflow of the team. This way, the audit does not rely on the effort of a certain group of people. It's built into the system. And this is what we're working on right now. To give a quick, that's what I have for surgical prophylaxis. Next, I'm going to discuss just a few slides on the other activities we've done. So prospective audit and feedback. It took us a while because we lost our daily antimicrobial reports, so it took us a while to generate that with the ISD Best Care team. And thanks to them, we were able to get a daily report where we had manual evaluation of patients on restricted antimicrobials in specific parts of the hospital. We chose ICU and hematology oncology because of our turnover of antimicrobials in those areas. And we found that around 37% of the audits that we did in 2018 were inappropriate. In pediatric, it was much less. What was interesting is that the prospective audit and feedback we did in pediatric ICU, you see the number of consults decreasing over time, and that's because the patients were either then, as soon as they were given broad spectrum antimicrobials, referred to ID, or because the antimicrobial, in addition to the fact that antimicrobial broad spectrum use was reducing because of our prospective audit and feedback. It was a combination of efforts. In the adults, however, we saw that, going back to the first slide, which is here, 37% were inappropriate. Of those 37%, mostly the most inappropriate item was choice. So we evaluated choice, dose, route, frequency, and duration. When you evaluate further the choice, we found that the most common inappropriate was for meropenem and vancomycin. And some further evaluation identified that it was mostly in sepsis and pneumonia that antibiotic use was inappropriate. So this is why we identified that we need to work on those clinical syndromes to improve antibiotic utilization in those areas. Of course, there were many other policies and procedures such as colistin, vancomycin, and aminoglycoside dosing guidelines. We also were implemented in conjunction with the Pharmaceutical Care Department a substitution of MER to ME, which is a cost reducing initiative that it's saved around 1.2 million SAR in 2018 and 19, and it's ongoing. Of course, this is a collaborative agreement, so there are specific exclusion criteria, but this kind of policies empower clinical pharmacists. We did a similar intervention of caspofungin to anidulafungin by clinical pharmacists, so in order also to save money, and we were able to save around 1.5 million SAR in 2019. And all throughout this time, while we were working on all these projects, we were working for 3 to 4 years on implementing a robust, safe way to implement antimicrobial restriction by creating an electronic process to ensure efficacy and safety, as I said. So this is some data from National Guard Jeddah, where I happened to be at the time. So we implemented restriction in a stepwise manner for different antibiotics till we got used to the system, till people around us got used to the system as well. And we also did see that antibiotic utilization in general decreased even outside of these restricted medications. It was able also to show us that internal medicine and ICU had the most number of restriction consultations. So it allows you to perhaps consider moving prospective audit and feedback to internal medicine next. One of the recent adjustments or interventions that we did is adding an indication for documentation, adding a requirement for documentation in all antimicrobial orders. So you can see here on the bottom right corner, the prescriber has to indicate why they think this patient requires an antibiotic. For example, here is Augmentin IV. And we were able to have some actions during the COVID-19 pandemic, which are all multidisciplinary with the ID and infectious and the clinical pharmacy team, such as the tocilizumab order set, COVID-19 treatment algorithms, and of course, including continuing prospective audit and feedback. So the take-home message of my talk today is that antimicrobial stewardship is about problem solving. You have to see what problems you have in your system and define how you want to move forward in solving them. There is no one way in implementing stewardship, and it's always a group effort. And you have to be creative in how you approach and communicate with people around you. I hope this presentation helps define stewardship for you in your mind and why it's important, and gives you some ideas of how to implement stewardship. I think this was supposed to be the last presentation. I don't know, Dr. Majid, maybe.
Yeah, thank you, Noor. Thank you very much.
Sure.
This was very fruitful and very informative. Just while, if you unshare yourself, please, while Dr. Asim, he came back to try to already share. Just will take 2 questions because we will not have a session for question and answer after. There are two questions only here. The one is about, can antibiotic be used for fungal and virus infections? What do you think, Dr. Noor?
Can antibiotics be used for fungal and viral infections? Well, this is a very good question. This is actually one of the main interventions as a stewardship program you can work on, which is marketing or sharing that antibiotics should not be used for fungal and viral infections. Antimicrobials in general kill microbes. Microbes include viruses, fungi, and bacteria, but antibiotics specifically kill bacteria only. So in the common flu, for example, or even in COVID, antibiotics will not help treat COVID, or antibiotics will not help treat Candida. They will only, impact bacteria. However, here is antibiotics will impact the bacteria around the fungus and the viruses in your body, and this is why you inadvertently may impact fungal and viral growth in any organism.
Yeah, but and one of the things people maybe they sometimes confuse between antimicrobial and antibiotics. So antimicrobials, under antimicrobials, they are antibiotics, antifungal, and antiviral.
Absolutely.
So antimicrobials is the big name. So under antimicrobials, it's antibiotics which treat bacteria, antifungal will treat fungal or fungus infection, and antivirus will treat, viral infection. And it's a commonly used that, or commonly wrongly, we give antibiotics for a viral infection. Let's say upper respiratory tract infection, which is now by guideline, it's not recommended that to give upper respiratory tract infections like sinusitis, especially the acute one, or sore throat, or anything with given antibiotic. We shouldn't. Okay.
Absolutely.
Yeah. The next question also, this is the last before going to Dr. Asim. What is the role of ASB pharmacists toward not restricted antibiotics, such
Sure.
as Trixone and Augmentin?
That's also a really nice question. So I guess that you could think of it in two ways. If you are working on stewardship in the neonatal ICU, for example, you may identify that ceftriaxone is one of your most broad spectrum antibiotics used in that area, in addition to aminoglycosides and carbapenems. So in that case, you may choose to restrict ceftriaxone in one way or another, depending on your facility. So this is just one thing that I'd like to say. But in general, let's say in the adult setting, ceftriaxone is not considered a restricted antibiotic. You have to define when you assess your utilization of antibiotics, you'll see, do you have a really high rate of ceftriaxone use? If so, where is it, in which department is it being used? What kind of patients are using ceftriaxone the most? In that case, you can address each antibiotic one by one. And this is why it's really important to get a baseline idea of what your consumption is like in your facility. You may think ceftriaxone is an issue, but actually it's cefuroxime. And so you shouldn't waste your time working on ceftriaxone IV, but it's actually cefuroxime oral as an outpatient basis. So the role of a stewardship pharmacist is to look for problems and try to find solutions for them, basically.
And very important, even if this drug is restricted, either ceftriaxone or cefuroxime or Augmentin, whatever in the system, and it's not under, clear restriction policy, like we have to create guidelines for people to understand. So the ASB pharmacist will create a guideline and will monitor people that they will use antibiotics, even not restricted antibiotic, per guideline. So we have to use it per guideline. And whenever we have it outside the guideline from indication point of view, or duration point of view, or dose point of view, the ASB pharmacist will look at it and try to fix it and to put it back into the right track, and maybe by educations and monitoring and auditing, and it's not only the pharmacist, issues of even the nurses and colleague physicians. They need to look at it carefully. So it doesn't mean that not restricted antibiotics we can prescribe it in whatever we
Freely.
No, it's not. So it has to be within a guideline, within indications, and a proper all other thing from route to dose to durations and frequency and everything. This is how we look to a stewardship program. I will take this as the last questions and I will answer it if you allow me. This is about how can we stop antibiotics prescribing for COVID-19 patients? And this is very difficult, questions. And again, maybe I highlighted in my presentation that how we can, save our patients from inadequate therapy or giving antibiotics early on whenever we have a sick patient. Let's say I have a sick patient with COVID-19 in the ICU. It's okay, maybe I'll give antibiotic early on. But the most important thing, and to do the cultures before, all the cultures, blood, sputum, urine, wherever we have something that we can collect and can explain if we have an infection or active infection, or use even some inflammatory markers like procalcitonin, and then guide ourselves later on based on culture, based on the inflammatory markers to de-escalate, stop, decrease the duration of antibiotics. And this is how we do things. And just not only I'm feeling happy to put a patient because it's sick, I justified, go ahead, start some antibiotics. You have to put some guidelines of what antibiotic you need to start in such conditions. But most importantly, you have to do all the cultures, do all inflammatory markers, and guide your therapy accordingly. De-escalate early, stop antibiotic only. Antibiotic not only will add burden on the patient from emergence of resistance, but also it may affect kidneys, liver, and other things. So we have to be very careful and monitor them, and all the time put a guideline in your hospital and follow them all the time. Follow international recommendation from WHO and CDC and hospital guideline how to use antibiotic appropriately, especially during pandemics. And with that, I'd say thank you very much, and I'll ask thank you, Noor, and I will ask Dr. Asim. I already introduced him, but I'll introduce him shortly. That Dr. Asim, he's a Associate Executive Director of Infection Prevention Control Program in Western regions, and he has a lot of initiative for stewardship program, and he will give us a talk about leadership in antimicrobial stewardship. So, Dr. Asim, go ahead, please.
Assalamu alaikum, everyone. I hope the sound and slides are okay now.
Yes, excellent.
Right. First of all, I would like to thank the organizing group for inviting me to present in the 5th Antimicrobial Stewardship course. In the next maybe 20 minutes, I will be speaking about leadership role in antimicrobial stewardship. So I would like to start with this slide, which basically clarify the relationship between the ASP as a program and the leadership. And it is a very interesting kind of relation. Both the ASP and leadership, they need each other. It is a mutual benefit kind of relation. The ASP people, they need the leadership to implement their program and have it achieving the goals that was put initially. And leaders, they need to support the ASP because it is important to their organization. It is a win-win situation. And let me show you why leaders themselves, they need to support the ASP program. First of all, the ASP improves outcome. And this is a goal that is interesting any leaders in any organization. There is accumulative evidence showing that every time there is an antibiotic management program, appropriateness of antibiotic prescription will be higher, cure rate among infected patients will be significantly higher, and failure rate among patients will be less. So this is basically a very important clinical and safety outcome that will be very interesting for any leader. Another reason is that ASP reduces resistance. So there is, again, huge amount of cumulative evidence over time showing that each time we implement some kind of antibiotic restriction activities, we will improve the susceptibility of some isolate against some antibiotics. This is an example of Pseudomonas aeruginosa with improvement of antibiotic susceptibility among different classes of antibiotics after implementation of antibiotic restriction program. So this is another important goal that will be very interesting for ASP to see in their organization. Another interesting point for the leaders to see in their organization is to see reduction of the adverse events. And a very good example that usually we take it in ASP is the rate of C. diff. So this is an example of the improvement that happened in the rate of C. diff after implementation of just the fluoroquinolones restriction. It went significantly down over time after that kind of restriction, and that continued over time. So this is a third outcome that will interest leaders in the ASP. This is not only those interesting points are not only clinical, but also it comes to logistics of the hospital. So availability of antibiotics will be better because consumption of antibiotic will be better, and that can be seen for in all antibiotics. This is basically depending on what kind of restriction list we have, but this has been clearly shown that every time we implement antibiotic restriction programs or antibiotic stewardship programs, control over antibiotic usage will be there, and this will be directly affecting the cost. Cost will reduce, and cost is very important drive that interest leaders in the ASP program. Another thing is that the ASP now is getting more importance as an accreditation requirement that has been already placed and stated clearly by the JCI. So it's JCI in 2017, they added the antimicrobial stewardship program as one of the requirements for the organizations. Also, it is now an important requirement for the local organization. So CBAHI is also mandating to that hospitals to have system of prescribing antibiotics. In addition, the ASP program is part of national initiative. So we have in Saudi Arabia, we have the National AMR Combating Plan, which was proposed in 2017 that was submitted to the WHO. And part of that national initiative, there was a recommendation to have ASP program implemented in all hospitals with more than 150 beds. So leaders will be interested also to support those national initiatives and to be part of that by implementing antimicrobial stewardship programs in their institutions. So clearly now we have seen that leaders should look at the ASP as an interesting case. If they support it, they will win. Their organization will be in a better shape. So the question now, how leaders can support the ASP? I can make it very simple in two main functions or two main columns. So the leaders, they can support the ASP structure, and their support is needed in the structure, and their support is also needed in the function. Let's take the structure first. So leaders, they need to appoint a senior executive leader to serve as a point of contact. This is very important to have a senior executive leader as a champion for the program at the level of the organization to help ensuring that the program has enough resources and to support to be supported to accomplish its mission. And we have seen this very clearly in the National Guard. So in the National Guard, we had this QPS Council resolution that was addressed in 2018. It stated clearly that the ASP will be under the official professional control, and the leader of the official professional control in the form of the executive director will be in charge of the program, and he will report the program activity to the CMO. So we have the CMO, we have the executive director of official professional under control. So this is a real leadership level of a point of contact and being champions for the program at the institution. Another role for the leadership to support the ASP structure is to support the establishment of a designated ASP team within the facility. Now we are talking now about the team that conduct the daily activity of the ASP program at different organizations. That team is accountable for the program implementation, management, and accountable for the outcomes of the program. And those team members, they need to have a specific function with clear delineation of responsibilities and expectations. And what we have here in National Guard, we are adopting the co-leadership model. So the good leadership in which we have an ID physician and the pharmacy expertise to lead the program, and that found to be one of the most effective model to have the ASP running smoothly. We have different teams at different organizations, but the typical team usually composed of an ID physician, infection control ID physician, a clinical pharmacy, an ID fellow, especially if there is a training program within the facility, and infection control practitioners. So those are the main core people who are running the daily business in the organization. Another area where we need the support of ASP or ASP structure is to support the training and education. And here I'm talking about two levels of training and education. Training of the ASP leaders or ASP members, physician and pharmacists, to obtain their specialized training in ASP. And we had this in National Guard. We have, for example, here in Jeddah, we have one ID physician who did a training in ASP, and we have a clinical pharmacist who did a training, specialized training in ASP. So this is something that we needed, and we need this to have. We need to have this more and more in all in medical cities. And also we need to have leaders to support the ASP education. That is the continuous educational activity and focused training that happen to the ASP members themselves and to other healthcare workers. And the very simple example of what we are doing today, we are doing an educational activity, awareness activity that will not have happened without the leadership support. Another role for leaders in supporting the ASP structure to support establishment of ASP committees at different levels. And here we have in National Guard a very good structure that we have a corporate ASP committee, and we have regional ASP committee at every single hospital or medical city. So we have a corporate ASP committee that is already established, which is led by a chair who is an ID physician, and we have a co-chair who is a clinical pharmacist. So basically here we are clearly empowering the co-leadership model in our organization, having leaders from the clinical ID and leader from the clinical pharmacy. And different hospitals, they have their own regional ASP committees. And usually the regional ASP committee include representatives from different clinical departments, in addition to microbiology, pharmacy, IST, nursing services, quality and patient services. So quality and patient safety department. So those are the people who look at the program implementation, challenges, outcome at the regional or hospital level. So now we are done with the structure part of the program that in which leadership support is needed. Let's move now to the functional part of the program where we need the leadership support. Number one, we need the leaders to endorse the ASP program officially. So we need to have their statement clear to support the implementation of the program at the organizational level. This is very important and essential to achieve the buy-in at different levels. And we have this in National Guard. We have this as through different office services that have been sent over years, endorsing different part of the program since the beginning. And we need also the leaders to empower the ASP team and give them authority. One of the very clear observations that we see it during our ASP activity, we are basically, I don't say conflicting, we are interfering with people work on daily basis. We have ASP people, they have access to clinical data, they have some control of over antibiotic prescription. So some clinicians, they will end up having their antibiotics, which was prescribed to their patient, stopped. This kind of intervention will not happen if the ASP people have not been given the empowerment and the authority that through the leadership to implement those kind of restrictions. We are, as an ASP group, we are proposing some additional rounds. So like for example, ICU, they will sit for their own ICU round, but they will find at one stage or at maybe on some days ASP people calling them for round. So now we are requesting additional services This will not be easy for people to accept without a strong leadership support and empowerment to the ASP group. Also, ASP people, they usually get some access to logistic data. They get access to microbiological data. They also go and evaluate and report some practices, wrong practices that can be corrected, or maybe they evaluate some kind of services or activities. For example, what Dr. Noor presented, the antibiotic prophylaxis or surgical antibiotic prophylaxis. So this is basically anesthesia, nursing, and surgical call to decide on the antibiotics. But here the ASP people are going to look at the practice and suggest some kind of improvement. So this is an intervention in some running business. That intervention will not be welcome if the ASP people have not been given empowerment through the leadership. Another role for the leaders to support the ASP function is to support the program with the needed resources, starting from the staffing, going to having staffing and their protected time to run the service, because most of the ASP groups are not dedicated only for ASP. They will do it in addition to their ID work or in addition to the clinical pharmacy work. So giving them the protected time to do the ASP work is something that is needed through the leaders. Resources like the materials for awareness and educational materials and rapid microbiological diagnostic. This is something very much needed by ASP to have rapid diagnosis, clear diagnosis, which will prevent abuse of the antibiotics before results are coming from the microbiology. So resources such like this is needed to be secured through the ASP, and new antibiotics is something that is always welcome through or brought through the ASP. So some examples of the resources that has been put in place through ASP in collaboration with other services over the last few years, the procalcitonin introduction, which had been introduced to the services through the ASP umbrella, multiplex PCR panels, which is helping now used for respiratory or GI or CNS infection, the CARB-R, which is looking at the resistant resistant Carbaminium genes among the Enterobacteriaceae, has been also implemented in our organization. Introduction of the new antibiotic like the ceftazidime avibactam and the ceftolozane tazobactam, which is also introduced in collaboration with other departments to address the issue of antibiotic resistance within the facility and to have it controlled under the ASP umbrella. And having the in-house COVID-19 test is a good also example of a rapid diagnostic that clearly influence the activity of the ASP, because if we have the diagnosis quickly, we will save the patient from being exposed to some combination antibiotics for some time until the result is available. Another area where the leadership support is needed, the ISD support, the ISD activity, and there is a long list of activities that are needed to be conducted through the ISD, and leadership support here is really needed, starting from the measures for the process, generating measures for the process, or generating measures for the outcome, or getting the proper microbiological data through the microbiology, including the, for example, the antibiogram data. Going into some pharmacy-based intervention like alerts for the duplicate therapy, or some mechanisms, ISD-based mechanism of detection of antibiotic-related drug-drug interaction, or automated adjustment of dosing, and going into more advanced clinical decision support system, which can advise on the best practices or even suggest the best antibiotics for a certain situation based on the patient characteristics and microbiology. So all of those are areas in which ISD support is really needed, and this support will not be secured without a strong leadership support. We here in the National Guard have achieved a lot in the ISD support. We did with their help lots of activities, but the list is still big, and still we are still doing lots of activities on manual basis, and still there is a big room for advancement here, inshallah. Finally, leadership role can be seen or is very vital when it comes to monitoring the ASP activity through regular updates and reports, which is needed to address the implementation, the progress, how the program is running. It is important to identify challenges and the required needs and resources, and to assess the outcome and goals from the program at the leadership level. And this has been clearly supported in our organization through the QBS resolution that recommended that the ASP program to be part of the regular chairman meeting as a standing agenda item. This is a very good step that is showing a clear support for the program implementation and a clear process of monitoring the activity on regular basis. So what we have seen now that the ASP as a program is very attractive for the leaders, but the leader support is very important and essential for the program structure and the program function. We are here in National Guard. We are in a very excellent situation comparing other institutions in the country and even outside. We achieved a lot, but our expectation and our goals are still not achieved. We are still looking for better outcomes, inshallah, and this will not happen without being together, working together, leaders and people at the ground and all other services, having them working together to achieve the success. And this is inshallah doable, and inshallah we achieve it very soon. So this is the end of my presentation. I'm very happy to receive any question if you have.
Shukran, Dr. Asim. Thank you very much for very important and subject for in the stewardship program, which is the leadership and how to apply the leadership and how to send and pass your agenda through the C-suite, which is the executive people, and let them support the stewardship program from idea point of view and manpower and also support to bring people all in the hospital from different sections to support the program. It's very important subject. Thank you very much for highlighting a lot of this important topic. Before going to ending this session, the first sessions, just one question here about the procalcitonin. Can we use procalcitonin to stop antibiotic? What do you think? Maybe Dr. Asim, can you answer this or?
Yeah, actually, this is one of the reasons why we introduced the procalcitonin to the organization, and this is one of the reasons why it was linked to the ASP. It was found that serial procalcitonin level in a right clinical context can guide you to decide when to stop the antibiotics and sometimes not to start the antibiotic upfront. So yes, we can base our judgment based on the procalcitonin in the right clinical context.
Okay. Oh, I think there are more questions now. Ghanima, is there any liaison with your OPD setting to continue the work of ASP team in the inpatient setting? I think it's a little bit complicated, but generally speaking, the communication among the team is very important. But we don't have this. We have outpatients, and they have their own antibiotic based on guideline prescribing guideline, and we have the inpatients where we have the setting there. We will have all the inpatient antibiotics related social program. And between them, though that the outpatient setting, I mean, in National Guard of stewardship is not well established, but generally speaking, they are a platform where all, people they sit together and discuss things together. How can you implement AMR in low resources hospital? Dr. Asim, what do you think? How we can start AMR in low resource hospital?
So AMR, antimicrobial resistant combating program, you mean, or ASP?
And I think they meant ASB.
Yeah. So from what we have seen from Dr. Noor presentation, that the ASP activities are wide. We don't need to have the full completed program to be established. I think you can assess your resources and look where to start. ASP activity can be done with a single person who is interested to look after the antibiotic prescription in the organization. We can make it simple like this. One person can look at it and he can start some activities. So you don't need to have a full completed program with all teams. You need to have, number one, the desire among the people to and the interest among the leadership. You need to have them buying in the idea. Then you need not a fully dedicated, maybe a part-time person who has the interest and some knowledge to start looking at it, and then put some kind of restriction, paper restriction, or through phone calls or through pager, but start some activities. This is by a function is an ASB activity. So start with your resources, but go after antibiotic prescription activities and monitor it.
Yeah, that's true. I would agree totally with Dr. Asim. Yani how we look to it, and maybe Dr. Noor already mentioned that before, the low-hanging fruit. So we need to see what's in your system that you can implement it easily. Let's say now I'm a very low resources, kind of hospital, and I can just maybe put a guideline how to treat pneumonia, or restrict one of the antibiotics that I think there is an abuse in the system, or start educating people about the importance of saving antibiotics and decrease the consumption of antimicrobials. You can do whatever element and processes to support the idea of stewardship program. Maybe you cannot establish a full stewardship program, but at least you can get some element, and this is acceptable by most of international bodies and accreditation bodies, where we have low resources and you need to establish some element, and every hospital, every primary healthcare, they need to have such kind of thinking, where we have just established small things. Whenever we cannot start big things, at least the small things need to be started towards stewardship program and saving antibiotics. Okay, with that we'll end our session. Thank you, Dr. Asim. Thank you, Dr. Noor. And we'll go to the next maybe session with who's who in stewardship, and I will leave the moderation to Dr. Noor to start the session. Thank you, everyone. Thanks again.
Thank you, Dr. Majid and Dr. Asim. All right, so we're moving to the next session entitled Who's Who in Stewardship, starting with Dr. Hajar Al-Qahtani. She is an infectious disease clinical pharmacist and working heavily in antimicrobial stewardship here at National Guard Riyadh. She's going to be talking about the pharmacist's role in antimicrobial stewardship. I'll leave the floor open to you, Dr. Hajar. We are running a little bit late, but we can pick up we have some leeway. So go ahead, Hajar.
Good morning, everyone. Thank you, Dr. Noor, for the introduction and for giving us the opportunity to participate in the webinar of the 5th Antimicrobial Stewardship Symposium. I have nothing to disclose. Today, we'll focus on the role of pharmacy services in ASP. We'll dive into different aspects of pharmacy and how would these aspects interact with each other and work in a complementary fashion, and end up with the recommendations on different initiatives that would profoundly impact pharmacists' role positively in ASP. I like this definition of ASP by Dr. Dyer. It is general, very basic, however, it's precise. What he said that ASP is a coherent set of actions which promote using antimicrobials in ways that ensure sustainable access to effective therapy for all who need them. Looking at the CDC's core elements of hospital ASP, we see pharmacist as a third core element. Starting with the pharmacist role in ASP, we need to understand that there are different levels of pharmacist involvement in ASP, which relies heavily on pharmacist competency level, and the level of post-grad education, specialty, scope of a practice, and area of interest as well. The opportunities to join is another issue, since some institutions, pharmacists may not have the ability or the opportunity to feed their passion or interest to participate in ASP because it doesn't exist. And finally, shortage in the clinical pharmacy manpower would definitely impact their ASP activity negatively. Starting with the level of involvement, in this study, which was conducted in France to evaluate the clinical pharmacist role in ASP and their impact on antibiotic consumption, they look at the most frequently encountered interventions made by clinical pharmacists that are related to the ASP, and they found that this a list of interventions, including therapeutic drug monitoring for aminoglycosides, vancomycin, some antifungals, providing antimicrobial education to their team, evaluating the appropriateness of antimicrobial therapy, including dose, frequency, duration of therapy, and converting IV to PO from IV to PO. Those set of ASP activities is done every day by our clinical pharmacist, which is really a huge role, and we need to just realize that they are a cornerstone of the this basic ASP initiatives. The question that I'm trying to address here in this slide, that do we really train our pharmacy resident or pharmacist to be a good stewardship pharmacist? This study was the first descriptive survey study characterized that tried to characterize the exposure of antimicrobial stewardship training for the PGY1 pharmacy resident from the RPD perspective. This study was conducted in the US. This study was an online survey distributed to the residency directors who examined resident exposure to antimicrobial stewardship activity. And the results indicated, as you can see in the table on the right side, that 50%, only 50% of the RBD feels that their residents had enough training doing ASP activities. Notably, with the current mandate of ID rotation with ASP rotation embedded together, facilities without an infectious disease pharmacist may be unable to accomplish the goals of the antimicrobial stewardship. And this might explain why third of the programs in the US, only third of the programs in the US require the ID rotation with ASP rotation embedded together as a mandatory rotation. However, we need to mention that clinical pharmacists have the ability to participate and lead stewardship efforts. Speaking of specialty here and scope of practice, we found that Infectious Disease Society of America identifies a clinical pharmacist with an infectious disease training as one of the two core antimicrobial stewardship team members. The Society of Infectious Disease Pharmacists, the American College of Clinical Pharmacy recommends any pharmacist to seek a clinical ID position to complete a PGY1 and then a PGY2 ID specialty residency. This leads us to discuss the differences between the stewardship team led by ID versus non-ID clinical pharmacists, which will be tackled in the next slide. As we can see here, the aim of this study was to compare the antimicrobial stewardship program activity conducted by a dedicated ID pharmacist versus non-ID, and we can find that at the hospital staffed by dedicated ID pharmacist, that almost 97% of patients received an initial antimicrobial therapy that adherent to the local guideline, compared to 87 in those hospitals that staffed by non-ID clinical pharmacists. And also we can see here that almost 87% of the patient had their therapy modified within the first 24 hours based on the laboratory parameters in hospitals which had dedicated ID pharmacists versus 72, and finally the almost 78% of those patients were determined not to be, where their illness was determined not to be caused by a bacterial infection. Antibiotics were discontinued in 78% in those hospitals with a dedicated ID pharmacist versus 33%. Here are some ASP initiatives that can be led by ID pharmacists that helps in promoting optimal utilization of antibiotics. More details in subsequent slides. Starting with our ultimate goal for promoting optimal use of antimicrobial agents, including appropriate selection of antibiotic with optimal dosing, rapid initiation of optimal therapy, and monitoring, and finally de-escalation or setting DOT. Utilizing electronic system that will help you to track all patients receiving antibiotics is awesome and great, and if you have it, that's good for you. This will help you to also implement other initiatives like antibiotic timeout, whether 48 or 72 hours, identify those patients with receiving an inappropriate antibiotic based on their microbiology results. That's what we call bug-drug mismatch, and also the prospective audit and feedback, the handshake stewardship. Also, we have a role in developing the therapeutic interchange in case of natural drug shortage, testing algorithms like, let's say, PCR Staph aureus nasopharyngeal, and de-escalating vancomycin for this patient with early pneumonia, ordering procalcitonin and when to repeat procalcitonin levels, and other treatment guidelines. Also, we ensure then that the number and types of antibiotics needed are available and appropriate for our population. So we do review our formulary and make sure that the needed antibiotics are there, and in general antimicrobials are there. So in GHA we have Avicaz and Zerbaxa, both are formulary and restricted to ID and other specialty with different levels. We also develop antimicrobial use policy that results in optimal use and reduce emergence of resistance. So implementing restrictions with the restrictions criteria, so we can identify this patient is eligible for, like, let's say, meropenem based on the restriction criteria. Evaluating the antibiotic consumptions in our institutions by conducting DOT per 1,000 patients per day, which we are working on. Working with our microbiology specialist to ensure appropriateness of the automated susceptibility test available, making sure that the panel we have, like, will just help us to get the susceptibility we need within like 24 hours instead of waiting for a longer time to conduct other tests to find the susceptibility. Establishing internal pharmacy policies that help us to prevent contamination of drug products. And finally, encouraging routine immunization of hospital staff. And this slide, I would like to, and the subsequent slides as well, I would like just to mention targeted strategies that I believe ID clinical pharmacists under the umbrella of ASP can do something about it, and we'll just try to tackle four of them. And I'm watching my watch now, so. Let's start with minimizing duration of therapy. We know that prescribing antibiotic treatment for the shortest duration possible is likely the most important method of achieving clinical success while reducing antibiotic resistance. So shorter duration associated with lower risk of antibiotic resistance. I picked up a gram-negative bacteremia because I was able to evaluate the recent studies published on the duration of therapy for uncomplicated gram-negative bacteremia with the source control. And they find that this is really something quite, I'm not going to say simple, but just it's a modest intervention, but it's really will save our patients. The first study was a multi-center prospective. It's one of the biggest studies, randomized trial that evaluated 600 patients with a monomicrobial gram-negative bacterial infection with achieved source control. 300 patients received 7 days of antibiotics versus 14 days. The majority of patients had their bacteremia caused by E. coli, followed by Klebsiella species, and then Pseudomonas species. And the main source was UTI, or urinary tract, and intra-abdominal infection. As you can see here, there was no difference in composite outcomes of 90-day, all mortality, cause mortality, infection relapse, and extended hospitalization. For the second study, which was retrospective multi-center observational propensity score matched study, included 249 patients with only Pseudomonas with a gram-negative with the Pseudomonas aeruginosa bacteremia. And they evaluated the differences between those patients who received a shorter duration of therapy with a range of 8 to 10 versus 14 to 17 days, and there was no difference in composite primary endpoint of 30-day mortality or reinfection. Second thing is the new prospective audit and feedback. PAF is commonly implemented as a part of the handshake stewardship, which entails review of prescribed antimicrobials and the provision of in-person feedback by the ASP team. The most success has been seen when incorporating concepts of behavioral science, such as peer comparison, accountable justification, and public commitment. I always think about PAF as a very safe platform to exchange knowledge and fill the gap wherever and educational opportunities, wherever you identify opportunity for that. Rapid diagnostic technology interventions, PCR-based technology for bloodstream infections. The positive impact of preventing this in the PCR-based technology for bloodstream infection in conjunction with the antimicrobial stewardship team notification and patient setting has been well described in the literature with a very, very promising outcomes, including minimize the time to optimizing therapy, shorter duration of shorter length of hospital stay, and therefore more cost, less cost, and also there's some data on like mortality benefit associated with utilizing PCR-based technology for a bloodstream infection. Staph aureus PCR nasopharyngeal for de-escalating vancomycin only for pneumonia I'm talking here about, and respiratory multiplex for to de-escalate atypical coverage. Clinical decision support and electronic medical record interventions, incorporating your guideline into the prescribing process, either by order sets, checklist, or alerts. It's something we're looking for in the future. Assessing beta-lactam allergy has been, my experience has been with in my residency that the ID pharmacist under the umbrella of ASP was the one who manage to evaluate patients with the beta-lactam allergy, doing the penicillin skin testing when needed, and sometimes we go with direct oral penicillin challenges when we feel more comfortable after evaluating patients, and when the allergy reaction is less severe. and kind of like doubtful, so we feel comfortable with going ahead and just de-challenge our patient or challenge our patient with oral penicillin. The last thing I would like to talk about is the pharmacy staff, the non-clinical staff. I believe that those manpower can be utilized in implementing or helping to implement some certain initiatives. So we have here the outpatient pharmacist and patient pharmacist and also pharmacy students. I believe that identifying initiatives that can match their knowledge and expertise and exposure to the patient would help us in the ASP to implement more initiatives and including more people on board. For the conclusion, antimicrobial stewardship is are going to get it's really getting more and more attention. Best solution for pharmacy is just to embrace the specialized people and people with like no specialty or with the generalists. The best way to conduct ASP by engaging a multidisciplinary approach, and finally be aware of the differences between effective and ineffective ASP. And by this slide, I'm going to conclude my presentation and open the floor for any question.
Thank you, Dr. Hajar. That was a really nice, targeted, detailed overview of the pharmacist's role in antimicrobial stewardship. If it's so, we're going to leave the questions to the end, not to the end, to the next section. But for now, I would like to introduce Dr. Dua Al-Jafri. She's going to be speaking about antimicrobial stewardship as a multidisciplinary team. Dr. Dua is an antimicrobial stewardship and infectious disease clinical pharmacist. She's also the director of the pharmacy residency program at the National Guard in Jeddah. She has a lot of experience in stewardship, and she will be taking over at this point. Dua, the floor is yours.
Thank you, Dr. Noor, for the introduction and for the opportunity to speak up for in this symposium. Do you guys hear me well?
Yes, you're clear and your slides are clear.
Awesome. So my objective for this presentation is just to convince you over the next 20, inshallah. I'm trying to just make it in 15 minutes. That everyone has a role in making a very impactful antimicrobial stewardship, no matter what. So everyone has a role in ASP, and yes, I have evidence to support my talk. When we talk about ASP team, there's always the core versus other essential team members. And as Dr. Asim said, or mentioned in his presentation, in most of the guideline, ID consultants and ID clinical pharmacists are the very two essential core members to implement a successful ASP program. But like he said as well, there are many very valuable members like infection control, IT, hospital administrators, and microbiologists who, without their help, we cannot maintain a successful ASP team. So to be fair, I'd say we need an army, not only a team. I thought this is a very, just a very excellent paper that support my talk. It's a pre-post single center time series analysis study where they intended to measure the impact of a post-prescription review and feedback. Just like a post-prescription preview feedback, or like in another simple word, prospective audit and feedback for carbapenems in particular. So as you can see here in the slide, their team composed of physicians, so respiratory and emergency physicians and pediatricians, and a full-time pharmacist, infection control nurse, and a microbiology technologist. Well, you can say like, wow, this is a huge team, right? they clearly, like in their paper, they clearly explain every single one of these people role and how many FTEs they needed. So I'd encourage you to read, the paper. But overall, they have 5 FTEs just dedicated for ASP team. So in their so basically, as you can see in the like the main intervention that they provided was providing a multidisciplinary round, composed of the listed in the slide members, and so basically, they reviewed patients and checked prescriptions for carbapenems, and they evaluated the use of on the run. They evaluated the use of carbapenems in those patients, and as you can tell, the average duration of the antibiotics therapy here was decreased from 9.9, as you can see in the figure, from 9.9 to 7.7 days. They also found out a significant increase in the de-escalation rate of carbapenems, percentage listed here for your reference. Well, I know we talk a lot about core elements or like core members, but in my presentation here today, I intend to shed some light on those key team members who work behind the scene, or those who I think can help big time, like nurses, microbiologists, trainees, including pharmacy and medical trainees of all levels, and last but not least, patients. So starting with nurses. Nurses are heavily involved in activities that directly relate to antibiotic use, and I believe the belief that an absence of partnership with nurses limits the success of an antibiotic stewardship program big time. So I have listed here some activities that nurses can help with, they definitely help with all the time, and I think I can go on and on and list other activities. But one of the very important activities, in my opinion, is questioning the medical necessity of urine cultures and ensuring proper culturing techniques and obtaining good allergy history. I thought I'd provide some data on the nurses, on some nurses-led ASP intervention, and not surprisingly, there is plenty of data about nurses-led ASP intervention. I picked up one here for you. So this is an observational it's actually an observational multiple group quasi-experimental study that was conducted over 3.5 years from July 2015 to December 2018. It aimed to characterize the impact of a bedside nurse driven rounds on antibiotic, urinary catheters or necessity of urinary catheters, and CVC use. And so they looked into the hospital, the hospital onset of C. difficile infection, the catheter-associated urinary tract infection incidence, and the central line associated bloodstream infection incidence. And so, like I said, they wanted to measure out the main intervention, which was rounds driven by nurses, involving an ID clinical pharmacist and an infection preventionist, mainly to implement the main interventions of questioning every single antibiotics that the patient is on for UTIs, or patients who have CVC or central venous catheters, and whether these interventions are needed. And so their recommendations were communicated directly to the primary team, and that was the main intervention that they made. So the outcomes were assessed in 2 cohorts based on time. And so as you can see here in the table, This was this was the cohort 1, and this was the cohort 1 which implemented in 1 telemetry unit, and this is the cohort 2, which was implemented in 2 telemetry units in January 2018. As you can tell here in the DOT, not only the DOT, the DDDs, there was a significant reduction in the monthly antibiotic days of therapy, or the DOTs per 1,000 days. And like a huge number of patients have been assessed. So 2,273 patients were assessed. 53% of these patients were just had interventions for like antibiotic use or like antibiotic de-escalation. 39% had interventions about their urinary catheters removal mainly, and 8% had CVC's removal intervention recommendations as well. So another group that has a very impactful role in ASP is clinical microbiologists, and I know like an ASP program wouldn't be a successful program without the help of a clinical microbiologist. So they help big time with stratifying antibiograms by location or sometimes by age, providing guidance on sampling collection or like the transporting of samples, and they help they provide huge help with rapid diagnostic testing if like they gave us the input from an ASP perspective. Now this is so as you know, antibiotic susceptibility testing report, like and antibiotic susceptibility testing results are reported usually like within the cultures, and we usually rely on antibiotic susceptibility testing in terms of deciding which is the right antimicrobial therapy. Selective reporting can be one of the huge intervention that most of the time microbiologists lead. So here in the slide, I listed a retrospective chart review that was conducted at 2 community teaching hospitals in adult patients who had a blood culture positive for gram-negative organisms susceptible to cefazolin, and who were empirically treated with broad-spectrum beta-lactam antibiotics. As you can see on the left, their cascade, this is their cascade. So gray boxes of antibiotics usually appears first, and then if resistant, they follow the cascade. And of course, this would have not happened without the big help from microbiologists, like I said. So they found out that the de-escalation from empiric broad-spectrum antibiotic to a narrower ones was significantly reduced, actually significantly increased in like post the implementation of this intervention versus before the implementation of the intervention. So this is one of the interventions that can be easily led by a microbiologist, and like wouldn't be done without the help of a microbiology. This is another study that I was actually one of the people who worked on this project with the rest of the group, where we prospectively evaluated the performance of the Accelerate Pheno system, which is one of the rapid diagnostics. And I know, inshallah, Dr. Maher later is going to talk about rapid diagnostics. So we evaluated the performance of the Accelerate Pheno system for identification and susceptibility testing of gram-negative species. This was a study that was mainly the person who led this study and has the huge impact, or the huge role, was actually a microbiologist, a clinical microbiologist. I mean, the result of this study is not as important, but it just shows that the introduction of this system and the implementation of such an intervention in our program was never going to happen without the help of this clinical microbiologist. Moving on to trainees. So trainees usually conduct ASP activities in diverse patient population. They can cover weekend, so they can provide an antimicrobial stewardship weekend coverage. They can run prospective audit and feedback rounds instead of ID consultants. So I know for a fact in our institution, usually ID fellows run prospective audit and feedback instead of ID consultants. And they can lead some focused interventions like dose optimization, IV to PO intervention, or like an IV to PO conversion. So here is another. So here is one of the examples that was conducted in like relatively large tertiary care hospital, teaching hospital. So I listed here the level of trainees included. So specialized pharmacy resident between ID and critical care. And the interventions that they led were mainly prospective audit and feedback, formulary restrictions, pre-authorization, and dose optimization. By the end of 2 years, so this, by the end of 1 year, so this was a review of 1 year period, and as you can tell, 1,443 interventions were made along the 1 year period, and not surprisingly, the antibiotic utilization decreased by 58 days of therapy per 1,000 patient days. So they have a huge role, and we can utilize this big time. In another paper that was conducted in 2 academic medical centers, where they included ID fellows, medical resident, medical student, pharmacy resident, and pharmacy students, and asked them to lead prospective audit and feedback, provide dose optimization, education, and de-escalation of therapy. And by an end of 2 year period, it was found that 2,266 interventions were made, with 90.5% acceptance rate by a primary team. So I think trainees has a very important role, and we should consider them, and we should actually take full advantage of our trainees to maintain a successful ASP program. In terms of patients, so none of us has any doubts that patient perception and expectations are often the reason of unnecessary antibiotics prescribing. And so I think most of the patients just need to know that antibiotics are unlike other drugs, where their use in one patient is likely going to compromise the efficacy in another. So I ran across this quality improvement project where they intended to study both of the patient and provider behaviors. And so the main objective of this study was like I said, it's just a quality improvement project where they educated providers and patients, and they wanted to check on their primary outcome was the reduction of overall antibiotic prescription rates for acute respiratory tract infection during the cold and flu season. So what are some of the activities that they have done? They provided just the Get Smart about antibiotic weeks material from CDC to patients. They had some posters throughout the office, like things we do all the time. videos played in the lobby about the importance of antibiotics and the importance of antibiotic resistance. They provided some brochures providing, like explaining the viral nature for most of the upper respiratory tract infections. And so, believe it or not, this intervention, this main intervention, without the help of any other interventions, reduced the antibiotic use for acute respiratory tract infection. From 69% at baseline to 56% after the intervention. This study was conducted among like 241 patients with upper respiratory tract infection. I think this is another study that I enjoyed reading myself. So what they did is, so mainly this is an interventional study that aimed to determine if the provider or if the provider provides an information leaflet on antibiotics with a delayed antibiotic prescription has any influence on the patient's decision to use the antibiotic for a respiratory tract infection. And so mainly there was a control group who were given a delayed prescription. And there was an intervention group who were given an information leaflet on antibiotics with the delayed prescription. This information leaflet just provided some information about the inappropriate use of antibiotics, and it just provided some insights that most of the acute respiratory tract infections are secondary to viral cause and not bacteria. So antibiotics are actually not helping in treating these infections. So what they found, as you can see here listed the result for you, the intervention group had 43%, like after implementation of the intervention, they found out that 43 of the patients only 43% of the patient only used antibiotics, whereas 72% of the control group has used antibiotics, with a significant difference, as you can tell. So I think the key conclusion here of the study is that delayed prescriptions should be issued with an antibiotic or with an appropriate information sheet. Patient decision, I think, in receiving antibiotics makes a huge difference if done well and appropriately. To end my presentation, or by the end of my presentation, I hope that I have convinced anyone who isn't convinced yet that everyone has a huge role in ASP, and that it's all about teamwork at the end. I think with that, I'll end my presentation, and I'm happy to answer any question if there is any.
Thank you, Dr. Da'a. Great talk. I think this really puts a good point to how important it is to have a lot of people on your team to give, have different approaches to the improvement in general. I think we'll leave the questions till after Dr. Wafa's talk, if that's okay. So the next speaker is Dr. Wafa Nasser. She is she's the Director of Infection Prevention and Control Department in our National Guard facility in Dammam. She will be speaking. Her topic is about the One Health approach to antimicrobial stewardship. Dr. Wafa, feel free to start. Great. We can see your slides.
Hello.
Yes, Dr. Wafa, we can hear you.
Good morning, everyone. Can everybody hear me?
Yeah, I can.
Okay. So thank you so much for this invitation. Special thanks to you, Noor, for all the efforts in organizing this symposium. So you probably saw that I've changed the title to Introduction to One Health, other than it used to be One Health Approach. it's an introduction because when I started reading this topic, I discovered that it's a huge, broad topic that need probably symposiums and courses to teach. So it's just an introduction to this topic. And let's just dive in. Just to make it more relevant, we're gonna start with a case. So this case was 3.5 or 4 years old, so it's not a COVID case, by the way. And it was given to me by a colleague who works in a private hospital. So this is a 64 years old gentleman known to have hypertension and coronary artery disease, had a history of cabbage, never smoked. He has no history of any hospital visit at least 6 months prior to this presentation, inpatient or outpatient, no recent antibiotic use. And that's what we ask our trainees to ask in the history to make sure that they don't have any risk factors for acquiring antimicrobial resistance. That's what we ask patients. He presented with 1 week history of productive cough and fever. He visited this private hospital 4 days prior and got azithromycin for, they say, chronic bronchitis. He didn't even get a chest x-ray, but he did not improve. So at this time, he presented to the hospital with fever. He was tachycardic in spite of beta blocker. His blood pressure was low to him. It's at least 20% lower than his baseline. And he was hypoxic, needed a face mask, 8 liters to maintain SAT. He looked sick, and he had bilateral crackles, right more than left. His labs showed basically goes with infection, and he has acute kidney injury. His renal function was totally fine a couple of days ago. His chest X-ray basically showed pneumonia. It showed infiltrates mainly on the right side, but he has a small one on the left side. So appropriate treatment was done in the ER, got fluids, got broad spectrum antibiotics. So he got actually cefepime, Vanco, and Moxie within 1.5 hours of his presentation. He was admitted to the ICU with this bilateral pneumonia and sepsis. He was placed on non-invasive ventilation in the ICU because of hypoxia. Unfortunately, he got intubated next day. The cefepime was changed to meropenem, and his initial respiratory sample, unfortunately, was just saliva, so it did not get much data about that. And basically, they changed antibiotics around. We'll talk about this in a moment, but he passed away 1 week after with respiratory failure and multi-organ failure. And this is his culture results. So he had Klebsiella pneumoniae that's multi-drug resistant. As you can see, it's resistant to meropenem. So we don't know what type of carbapenemase is this, but it doesn't matter. So are you guys surprised? I just want to hear some noise. Unmute your mics for a moment and tell me if you're surprised or not.
Hi, Dr. Wafa. Unfortunately, the attendees cannot unmute their mics.
So,
but maybe they can write some comments in the Q&A part. No, unfortunately, yeah. I'm not surprised. Yeah.
So we're not surprised. Somebody could argue that this patient could have, for example, strep pneumo or community-acquired MRSA and die with it. Why does it matter? It does matter. So if we know if from the history that the patient is at risk for acquiring multi-drug resistant organism, we know that empirical therapy matters. We know that if he gets the appropriate therapy, and Dr. Asim alluded to that, if he gets appropriate empirical therapy, his chance of survival and outcome improves. So it really matters to know if the patient is at risk of acquiring resistance or not. So the team then went in a mission to try to find out what is the possible infection source in him, because he's not supposed to have resistance, or people were surprised, although in the ID community we never get surprised. So they sent a trainee. It was an intern. It was a female intern, and she asked all sorts of questions. So I got this from them actually. So he thought of the wife who has an end-stage kidney disease on regular hemodialysis. Her last admission was 2 months ago with line infection, and she remained in the hospital for around a week. And then she got antibiotics as an outpatient after her dialysis sessions in the dialysis center. Then his grandson, so his son and his daughter-in-law were recently in India. So their son had a tumor in his kidneys, probably it's a Wilms tumor, and they went for a second opinion, and they stayed in the hospital for investigation for around 5 days. Both parents stayed with the son in the hospital for 5 days. So this could be another source. Also, his friend who was last month admitted in another hospital for heart failure, but he spent over a month in the hospital and he was intubated in the ICU. So this was to them another source. He has a small farm, believe it or not. He has a small farm that he actually has some animals like sheep. He has chicken, he has dogs and cats in the farm, and he have plants. He still plants and he still sheep from that small farm. They have also a veterinarian doctor that visit the farm almost every 1 or 2 weeks to look at the health of animals there. He has a daughter who has 2 kittens. By the way, this is my cat, Snowbell. She died a couple of years ago. Don't be upset. She didn't die of infection. But actually, every time my driver takes Snowbell to the doctor, for 3 times for a regular visit, she gets antibiotic. I couldn't even read what antibiotic is, and I called the doctor the 4th time, and he told me this is a 3rd generation cephalosporin that actually increases their immunity and it prevents infections. So I told him, please, 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 I didn't tell them that I'm a doctor, please, next time, don't give her antibiotic till you talk to me. So I would know I'd like to know the indication of the antibiotics. Could he get it? This is from me, but it could he have gotten it from water that he's drinking or food, the regular food we're eating? So you could live in a bubble because this is our comfort zone in the hospital and say, I'm gonna do my job. I'm gonna make sure that every antibiotic in my hospital is appropriate, which is an impossible mission. You cannot do that. But you could do that and be naive to think that you will never have resistance in your hospital. That's too naive because you're part of this community. So patients and workers in the hospital come and go. They go to the community, they come back, they eat food that might have resistance, they eat meat, they eat plants and fish, and they come back to the hospital. We generate waste in the hospital that have some empty bottles of antibiotics, expired antimicrobials, and these waste, we don't know the way it got treated. It goes to the water and soil and then goes back to our patients and they come back to our hospital. We're also part of this circuit. So patients get transferred from another hospital that maybe doesn't have as much of a strong antimicrobial stewardship program like yours, and you would never escape this antimicrobial resistance battle. So although the antimicrobial resistance and combating it is our ultimate mission in actually fighting antimicrobial resistance and this antimicrobial steward programs, but it's a small part of what we call as the One Health approach and One Health concept, which is our topic for today. So there are so many definitions for One Health concept. I chose the CDC, but this is to your right is the WHO, FAO, which is the Food Agriculture Organization, and the Animal Organization combined definition. So, but it's almost the same. So it's defined as a collaborative, multi-sectoral, and a transdisciplinary approach working at a local, regional, national, and a global level with the goal of achieving optimal health for all living creatures, basically. And it's not a new concept. When I read about it, it used to at least it started by the Greeks. Here we find that Hippocrates, for example, talks about the environment on earth, water, and place in a way to promote public health and prevent diseases. So it's not a new concept. And then in the 19th and 20th century, it was all about one approach to prevent zoonotic infection, basically. So we find Virchow and Schwab, which are the most famous in these fields, talking about animal and patient's health and environment as well. And then we started to have, probably in the last 15 years, a more broad concept of One Health, approaching many problems, including chronic illnesses that are not infectious in nature. And to be honest, it was all about zoonotic diseases in the past. That's why we did not have a very clear picture of One Health approach, but it was extremely successful. But now they're looking at many other topics like food safety, vector-borne diseases, environmental health, chronic diseases, mental health and occupational health, and eco-health as well. And there are a lot of success stories. If you read, you're going to find stories in Africa and Asia about controlling diseases, zoonotic diseases and vector-borne, like brucellosis, Q fever, malaria, dengue, Ebola, SARS, Rift Valley, bird flu, and even MERS. We had the One Health approach, actually courses in here in Saudi Arabia try to tackle MERS corona. But when it comes to resistance, the picture is much more complicated, because it's not only about antimicrobials, unfortunately. So the drivers of resistance is extremely broad. So we have the antimicrobials, which we can control to some extent, but we have a lot of biocides like insecticides and pesticides and disinfectants and sterilizers that go to our communities, and we don't know the effect of those, to be honest. And I was thinking last week, reading about this topic, what can happen with all these infectants we're using now with COVID and goes to our environment? Would we have an effect in the near future with antimicrobial resistance emerging in all over the world? And then you have heavy metals that have the antimicrobial activity, and of course there is natural mutations and antimicrobial resistance that happen naturally. We haven't just to accelerate it as humans really badly. And then we have the agriculture use of antibiotics in agriculture and plants, and there's tons of prophylactic antibiotics that's used for this. The animal husbandry is a huge topic. It's extremely interesting. I read several articles about it, and most of the developed countries have banned the use, at least of using antibiotics as the growth promoters, but in many parts of the world is still having those antibiotics in feeds and water, not only for the growth, but actually to compensate for bad hygiene. So you have very crowded places and you have poor sanitation. So they compensate for that by giving the animals antibiotics, which is very poor practice. There are good indications for antibiotics in animals, but the broad use of antibiotics is really bad. And then we have, of course, the household and industry that dumps the sewage, and we don't know how the sewage gets treated and goes to our water and soil. It comes back to us. So it's really complicated. And to make it more complicated, the humans' use of antibiotics is only 1/3, maybe less than 1/3. Most of the use of antibiotics in agriculture and animals are not very well controlled, although we have some legislations in there, but enforcing it is extremely difficult task. In developed countries, they have some surveillance in the animal and agriculture. I didn't read any in Saudi Arabia or in the GCC, except for some in the poultry. So I don't know if we have some policies and procedures even here, but I don't know how good its enforcement. In addition to that, to make it more complicated, I will not talk about the whole thing, but we have the travel, the tourism in general, whether it's medical, regular, religious tourism. We have the global trade. We have the climate change, which we're gonna just touch on in a moment. We have bird migration, and we have pests and flies, and we have intrusion of the habitat of the wildlife. We do a lot of harm as a human, as you know. This is about climate change, and I love this slide because it describes some of the effects of the climate change on infectious diseases. So you could have extremes of weather like flood, for example, and you have contamination of crops by feces at high levels. So it affects we might acquire resistance just because of that, or you might have very high temperature, for example, that cause food scarcity and poverty. Increased poverty, as you know, would increase transmission of bacteria from one person to another. Hunger would cause people to seek the food from everywhere, including contaminated food, unfortunately. And then you have, because of the extreme temperature, high temperature, you might have even water scarcity, which causes poor hygiene and sanitation. And as we know, bacteria and other organisms survive much more under higher temperature, and sometimes some organisms under lower temperature, but the high temperature increase the multiplication of bacteria. So Dr. Asim mentioned that. So we have a national AMR, combating AMR guidelines, policies. This was the 2017, which is the last one, and we should be proud of it because I read it last week and it's extremely comprehensive. It has most of the objectives. I think we improved in a lot of these. We improved in, at least in our building laboratory capacity to look for AMR. We improved our national infection prevention and control programs remarkably in the last couple of years. We improved our antimicrobial stewardship programs. Currently, we have probably some elements of ASB in every hospital in Saudi Arabia because, as other speakers mentioned, it's a Sabahi requirement and a JCI requirement, but we could do we have room of improvement in the increasing awareness. In this AMR policy, it talks about embedding the AMR awareness in undergrad and postgrad, not only for medical students and trainees, but for everyone and for the community. I don't know if that's already done in our country, because we have trainees here, like students and interns, that know nothing about ASB or AMR problems. And to be honest, for the animal part, infection control in the animal setting, or the ASB in the animal setting, I don't know much about. There were studies in 2002 in here that they have surveillance of antibiotic use in poultry and chicken. I forget the author, but they saw a lot of abuse of antibiotics in poultry. So there was a huge gap for improvement, but I don't know how much success did we have so far, to be honest. It's a topic out of reach. So what do we need to do? So at least we need to acknowledge the problem and collaborate. Don't live in this bubble in your hospital and say that I'm going to control antibiotics use in my hospital. I have nothing to do with other things. So, no, you can't do that. So we need to reduce the need for exposures for antimicrobial by improving our infection prevention and control program, improving the water quality and food safety, we talked about this, animal prevention and control, and then we need to optimize use of medicines, whether it's in human, animal, and plants, increasing laboratory capacity and surveillance, and then we need to invest in innovation, whether it's research or diagnostics or therapeutics or vaccines, to be able to achieve a One Health approach to problems. And something that we really lack or we don't think about a lot is improving the environment. And it's another huge topic, but pre-treatment of manure before use is a big thing all over the world. Consider pre-treatment of waste in the slaughterhouses before generating it to the general sewage system, ensuring evidence-informed use of antimicrobials and as pesticides for crops. We need to hold the pharmaceutical industry accountable. They need to be part of the surveillance for AMR and surveillance for antibiotic use in animals and plants. They need to monitor residues. This is done in developed countries where meat cannot be sold without checking the level of the antibiotic in them. I don't know if this is done here, to be honest. I know that when you are sending meat outside, so when you are exporting food from Saudi Arabia, you need to monitor antibiotic use. But in slaughterhouses and small farms, do we do that? Do we like the slaughterhouses? Do we just get the waste immediately to the residual waste system without checking antibiotics and without treating it? We need to have some cost-effective, energy-efficient technologies for waste, like invest in ozone treatment, activated carbon, biofilters, and UV disinfection of waste. And the most difficult thing, of course, is the social behavioral interventions. I think we need to talk to each other. You know, we live here in our hospitals and thinking that we don't need to talk to veterinarians or farmers or other people in the community. If we want to achieve a good AMR and antimicrobial stewardship, we need to educate people outside the hospital, be part of the community discussion about this topic, because if we have any single threat globally to this world, it's going to be AMR, as you know. Thank you. I tried to do just like 10 minutes or 15 minutes talk. Thank you.
Thank you, Dr. Wafa, for that very passionate talk. I think it's clear that this is something that we all struggle with, because as practitioners, we see patients coming in from the community. You're trying your best to do things on a very local level in your facility, but then you see that there's a lot more that needs to be done on the community setting, on a national level as well. So I think we have time for one question for you, Dr. Wafa. So I know that you've discussed thoroughly in you know, the different concepts of how to incorporate stewardship or the prudent use of antimicrobials into our community, whether it be poultry or agriculture, waste management, and different things. But what would you like your audience to remember and to take home today from your talk?
Probably that AMR and stewardship need to be really comprehensive to tackle resistance. So we need the people in the community to be part of this and aware of this. We have a huge threat because of AMR. So even for their individual use of antibiotics, it needs to be directed by a physician. They need to stick to and adhere to what their physicians say about the course and the dose. They should not seek buying antibiotics. I know they cannot buy antibiotics now without a prescription in the country, but a lot of people get antibiotics even from outside. We need to think, if you do plants and if you have animals, we need to think about stewardship in those animals as well. Don't think that giving your animals or giving plants antibiotics will increase their survival or will make them more healthier. It's going to be more dangerous to them and to humans in the future. So they need to look ahead and look at the future, not only their point of treatment at that moment. So they need to think broadly, because this AMR gonna hunt them very, very soon in the farm, in animal, in the plant industry, and it's gonna cause more damage, and it's gonna cost more. So we need to think about this broadly, not only the use of antibiotic in humans, but in others and other settings like animal and plants and in the environment.
Absolutely. And then this also links into Dr. Dua Al-Jafri's talk about how everybody needs to come in as a team, whether be it physicians, pharmacists, nurses, housekeepers, residents, everybody. And so thank you both for your talk. Now is the time that we can move forward to the recognition and award ceremony. So in light of the Antibiotic Awareness Week and all the activities that the different regions are doing, as well as different hospitals, we have just a small appreciation ceremony for our colleagues here, and also there will be an opportunity for each director from each area to just mention what they've discussed. Dr. Wafa, I don't know if you will have time to stay with us, but you can start first if you need to go.
Unfortunately, Noor, I have to go.
Okay. Yeah. No worries. All right. Thank you very much for joining us. I will mention your activities on your behalf. Thank you for allowing me to do so. Okay, so now we're moving forward with the recognition and award ceremony. So we usually have this these symposiums on in hallways and not in hallways, of course, in halls, and it would be a lot more personal. So this is what the time that we usually thank our colleagues and our different members for all their work throughout the year, and also we would recognize certain people that had specific large impacts. But I'm talking here on a very, corporate level. We really want to thank the hospital leadership, the pharmaceutical care department. Specifically, I'm thanking in my region, Dr. Naaman Abdan, Dr. Abir Asmari, and the pharmacy residents, but I know Dr. Asiri and the different pharmacy directors in all regions are really big supporters. The infectious diseases teams, Dr. Abdurrahman Saadi and Ibrahim Mahmoud, of course, also Dr. Muhammad Zahrani, Dr. Thaqafi, and I can't say everyone's name, so please forgive me if I mention certain people. There's also really, really big, important part to ISD Best Care and Clinical Performance Improvement Unit that are really helping us. Nursing, pathology, and microbiology, quality, and of course the medical and surgical departments within all specialties, OB, oncology, of course. Within Riyadh, specifically Dr. Jamil Anazi for coordinating with us with the residents. The deanship and postgraduate education, Mr. Farian and Ms. Rab'a. Housekeeping, because within the same spirit of multidisciplinary approach, the housekeepers are really, really big part of our hygiene and keeping the area safe for our patients and for us. All support services, of printing press even, that helped us print some material for all regions. And of course, the whole infection prevention control department team. I can't mention everyone's name, but our admin assistants, Ms. Faye, Brittany, Wid, Fatma Dawood, our infection control practitioner, Muayyad. I'm speaking on behalf of Riyadh at this point. Just so for all the attendees to know why we're sharing this, we also want you to share, because stewardship is also about sharing what we were able to do. And hopefully, I'm really happy to help anyone from outside to give more insight about what we've done. But we have this symposium, we have another symposium that's ongoing all week on different days of the week. We have ICPs doing nursing huddles talking about stewardship here in Riyadh, satellite events presented by clinical pharmacists and ID physicians throughout the week for different target audiences. We had an e-learning quiz, and now is the time for prizes. So these are the names of the 3 winners of the quiz that we allowed nurses to do yesterday. We gave the opportunity for nurses to do this quiz, and Charvi Sizon, Dayang Masalis, and Annabelle Harmo were the ones who won for this quiz. We'll contact you later by email. We also had an Antibiotic Awareness Week poster competition, and we had 2 winners in KMC and 2 winners in Cash, which are our 2 main hospitals here at National Guard Riyadh. So Mr. Manuel Carmen and Mr. Ronald Asireda made really beautiful posters to try to, the role or the goal of these activities is to involve end users or end providers, such as in this case nurses, to read and interpret what they've read in their own way. And this is why we love this activity. In Cash, the winners were Ward 53 and Ward 47, 48 representatives, Ms. Janelle, CT, Noor, Nikki, and Amthal. And Ward 47, Ms. Karen Salang, and they will get a small appreciation certificate from us, as in addition to a small prize. Well, not a small, but it cannot be enough to repay them for all the work that they've done in these beautiful posters. Mr. Turki Swailem, Manager of Environmental Health, in addition to Ms. Tina and Ms. Regina, helped us organize educational activities with housekeepers, and we had a quiz for housekeepers as well. It was also slightly about the One Health approach, environmental health, and stewardship, in addition to practical ways of that Mr. Turki identified would be important to share with them. And the winners are here. We will also contact them: Mr. Abdul Ati Kalpana, Edemir, Miss Janet, Wasana, and Joel. Excuse me if I'm mispronouncing names. One of the nice activities that we've had for the past couple of years, and today we repeated, was a clinical skills competition for residents. And the winners are Dr. Janadi, Dr. Fahad, Dr. Faris Saleh. We'll also contact them. This is also really important for those of you in the audience who've asked, how do we start, or we're not sure how to start. This is a really nice free certificate online that people can do. It's an antimicrobial stewardship certificate. So we sent an email out saying, whoever, we will pick 3 names randomly to appreciate you with a small prize, but I also wanted to appreciate the others who did the certificate, and these are their names, 7 participants. The ones in red will get the prize, but everyone else will get a certificate from us as well as appreciation. Last but not least, talking about reaching different target audiences, we will throughout the week we've built this. We've had this handout for quite a while, but we translated it this year to Malay, to Tagalog, and Urdu, and hopefully looking forward to translating to other languages. It's a very short educational handout that we can use with target audiences that will not be comfortable reading Arabic or English. So I'm really grateful to those who helped me translate this item. And on behalf of Dr. Wafa, I'm just going to share what Dr. Wafa and Dammam has been able to do. In their activities, they had flyers and posters all over the hospital on different elements of stewardship, targeting patients and staff. They coordinated with Dr. Ahmed Lanizi and Dr. Consuela, I think, to have a discussion with physician groups about vancomycin dosing and IV to PO switch guidelines. They had a booklet targeting physicians, and they had a competition. This is a really nice competition. They had a competition with the best idea to improve antibiotic use in different patients, and the best 3 ideas will be awarded. These are some of their educational material. And it's really adequate now, or appropriate with COVID, I guess, with the masks. And JHA Jeddah will, I think Dr. Maher Al-Ahmadi should be with us. He will discuss their activities. Dr. Maher.
Can you hear me? Assalamu alaikum jami'an.
Wa alaikum salam. Yes, we can hear you clearly.
Yes, good afternoon. Thank you, Dr. Noor, for your organization for this symposium. So I'm going to go quickly about what are the activity in Jeddah. I'm going to share with you my presentation. Can you do unshare, Noor?
Sure, go ahead.
Is it clear now?
Yes.
Okay. So we have some similar activities with you. So in Jeddah, we are for the 5th time since the antimicrobial stewardship was established in 2016. We participate in the Antibiotic Awareness Week. This year was different because of the COVID pandemic, and most of our activities was virtual or through online. We have the 5th Antimicrobial Stewardship Symposium, which is a unified webinar with Riyadh, in addition to WHO Antimicrobial Stewardship online course. So healthcare worker can complete the course and send the certificate before 24th of the November. And also we have the clinical skill competition in antimicrobial stewardship. And this year we tried to expand the clinical skill competition. We went to the surgical department, and in addition to medicine, internal medicine, we went to a surgery department and also to the pharmacy resident. And we have our appreciation appreciation ceremony. Inshallah, it will be on Thursday, 26th of November, and inshallah we will announce the winner for that. So this is the office service that was sent, and the clinical skill competition, as I mentioned. This year also we try to be like to targeting our colleague in primary healthcare. So inshallah there will be a 1-hour webinar that targeting all primary healthcare centers in Western region, including Jeddah, Sharaya, Taif, to try to engage primary healthcare in our activity. It will be inshallah 1-hour webinar. You are welcome from any region to attend this webinar. Inshallah it will be on Wednesday, inshallah, early morning at 8:15. And many satellite events was done by my colleague Dr. Dua Naeem, for example, targeting the nursing department in the title and handling antibiotic with care for nurses. Also my colleague Dr. Nader Damfo, also he's an infectious disease clinical pharmacist, talking about important topic about empiric antibiotic use in COVID-19, pneumonia, targeting internal medicine department. And Dr. Dual Jeffrey also targeting emergency department in the title of asymptomatic bacteriuria, when to screen and when to treat. Many hospital-wide education through screensaver with important antibiotic related message, and posters, flyer also in the clinics. And this is the final slide, our message for the events. Thank you so much.
This is a really nice overview. Thank you, Dr. Maher. Now we can move to Dr. Sayed Nazir. I'm just gonna share. One second.
Yeah, can you hear me?
Yes, we can hear you. I'm just sharing the slides. There we go. Go ahead, Dr. Nazir.
Yeah, so thanks for this opportunity, and I would like to share that this Antibiotic Awareness Week in Pamba. So this slide is showing the theme of this Antibiotic Awareness Week, that we unite to preserve antimicrobials, and the slogan is handle antibiotic with care. So the next slide. So our team here consists of Hawazan, she's our public health nurse, Iman Abrar is our clinical pharmacist, and Dr. Tariq, he is at PHC. So they basically took the lead and took this campaign. But one thing I would like to mention here, that our team took this campaign when we were overwhelmed with the COVID surge. And since February, the last 2-3 weeks were the highest surge that we had, since the outbreak of this COVID since February. But despite these time constraints and being overwhelmed, I appreciate my team. They took the time out, and they took the campaign. The next slide. So the activities that we did awareness rounds for patients, staff, military, housekeeping. And there are quizzes for different category of staff, for healthcare workers, for housekeepers, for nurses, for doctors. Abrar, or clinical pharmacist, she made the quizzes with the clinical scenarios for the physicians. And we distributed the flyers, the posters regarding awareness about stewardship symposium. antibiotic awareness poster competition. Our deadline is 5 p.m. on the 25th, and also for the competition for the achievers of WHO online competency course, the deadline is 25th. So on the 26th we have the prize, for the achievers, and the gift vouchers for the achievers. And we did disseminate the screensavers in the waiting areas and the physician office computers with the key messages about, to save antibiotics, that this is our precious resource. So this was of Pamba, and again, I appreciate and thank for all departments here who supported us, including our executive directors, pharmacy, environmental nursing services, media services, and special thanks to the excellent team in Riyadh who made this job very easy for us, and we appreciate their coordination and kind support. Thank you.
Dr. Noor, is mute. We can't hear you. We can't hear you, Dr. Noor. No, still has a problem.
All right.
Okay.
How about now? All right.
No.
Okay. Okay, great. Sorry, apologies. I was just thanking Dr. Nazir about and Dr. Maher and all regions for all their work during COVID. I know it's been really hectic with everybody's efforts and being kind of dwindled with COVID and resistance, which is also just as important. I will just, for the last 10 seconds here, I'll just describe National Guard Hassa's work led by Dr. Abdelmajid Arfaj, and he shared this with me, discussing how they will conduct stewardship rounds, educational rounds, and during the rounds where they will emphasize briefly about what stewardship is doing in AHSA, discuss prevalence of MDROs and their local data, talk about the antimicrobial usage, de-escalation, the impact of the antibiogram. They will discuss the role of each healthcare worker, including nurses and physicians and ASP. They will have a quiz at the end of the session with prizes for the highest score, and they will distribute antimicrobial awareness flyers to inpatient and outpatients, targeting the public and healthcare workers. So I know this sounds a bit not usual to describe all of these things within a webinar or symposium, but this is also part of stewardship, and we hope that all of you may, also in the future, I'm sure many of you have your own events, but I hope you can also start by having small educational activities around the same time every year, aligning with the World Antibiotic Awareness Week. With no further ado, I'd like to introduce Dr. Syed Nazir. Dr. Nazir is an infectious disease consultant, and he's also the director of Infection Prevention and Control Department at National Guard facility Prince Mohammed bin Abdulaziz Hospital in Medina. Dr. Nazir is going to be speaking about the approach to optimal antimicrobial prescribing. And please, Dr. Nazir, the floor is yours. We'll leave the questions till the end, and hope we are running a bit late, so I hope you can stay with us. But I think we'll be fine. Go ahead, Dr. Nazir.
Yeah, can you hear me?
Yes.
Okay. Okay, thank you very much, Dr. Noor, for the nice introduction. So the topic of my today's talk is approach to optimal antibiotic prescription. The objective of my talk is to know the 5 Ds of appropriate antibiotic therapy, to know the interaction of pathogen, patient, and drug, along with various related factors in optimal antibiotic use, and to understand basic pharmacokinetic and pharmacodynamic indices for optimization of antibiotic therapy. So this first slide that shows can you see my slide? Yeah, can you hear me?
Yes, we can hear you.
Okay. So if I go to the slide presentation, does I lose my slide?
No.
No, it's.
Yeah, I think something. Let me reload my slide. Can you see my slide now?
Right now we see your screen, which has the slides on the left side, left side, sorry. If you do from slideshow.
Because I can see only the left side, but I can't see the main in the center. Something has gone wrong, I think.
If you just click next, what happens?
Nothing. The screen remains blank.
Maybe if you can X out of your presentation and so the slides are clearly working, but maybe there's something wrong with the media for some reason. Maybe if you can X out of the presentation and reload.
Yeah, let me try. Yeah, can you see the slide now?
Yes.
No, I think something wrong here. Let me just. Okay. You have here? Okay. Let me try to reload.
Would you rather, if Dr. Maher is available, I'm not sure if he's around, would you rather we switch things around, or do you want to try one more time?
Let me try one more time.
Sure.
If it doesn't work, then we'll switch.
Sure, absolutely.
Something wrong here. This one.
We can see the optimization of antibiotic part, but I think there's maybe an issue with the photos. But maybe would you like me to try to upload your slides?
Yeah, I think if that will work, I think maybe.
Let me try that. Yes, if you unshare and then yeah.
We cannot directly do it from here. Yeah. Copy the computer. Oh, this is not right. Just download from here. Yeah.
This is done. Okay. yours? Yeah, this is yours. We can do this. Wait, we quickly show you. There's a way. We can do this one. Here, this one, screen. This way you're sharing the screen.
Okay, can you see my slide now? Yeah, I think this is working now.
Yes, this looks good.
Yeah, okay. So I'll try to compensate for the time, so bear with me.
No worries, but if you can reduce the...
Sure.
Oh, no, it looks good. Never mind.
Okay, so this is a cave which was isolated from the planet of the Earth for 4 million years, and the scientists discovered, and they found bacteria here, at the depth of 1,000 feet, which were resistant to even current antibiotics, for example, like daptomycin. So this was intriguing that, how come these bacteria acquire resistance to the antibiotics they never saw, because many of these antibiotics are semi-synthetic and they're not occurring in nature. So that shows that this resistant gene and the evolution has been going on for billions of years ago. And when they are faced with the antibiotics, what happens? This is a phenomenon of selective pressure. Here in this slide, you can see that on the left side in the orange, these bacteria are sensitive, susceptible to antibiotics, while the one in the blue is resistant. Once the antibiotic is they are exposed to antibiotic, it kills the susceptible organisms, leaving the resistant one. And then the resistant one, they find free space, to multiply and colonize and then cause an infection. So basically, the resistance genes and the mechanism have been there in these bacteria for millions of years, and these resistant bacteria is going to stay with us. So what we need to do is to optimize antibiotic use. And this slide shows a phenomena that the world or the people uses for common resources. For example, in the globe, there the resource is the fish, which we can correlate with antibiotics. So people, they catch the fish without paying any attention to the depletion of the resource for the future. And what happens that the source is depleted and the community by large suffer. So same happens with antibiotics, that when we use them, so we don't deplete them, but we render them ineffective due to the acquisition of resistance. So this abuse makes the society suffer, and the consequences are catastrophic. So this term is called tragedy of commons, and it results when individuals undertake an action that they perceive to be in their own self-interest, but which causes harm to society at large. So this is what happens, and WHO has already confirmed that the world is running out of antibiotics, and there are very few novel antibiotics in the pipeline. So this one of the key strategies to optimize the use of antibiotics. But in the optimization, it's a very fine balance. On one hand, we have the inappropriate therapy associated with increased mortality, and on the other hand, the resistance and adverse outcomes with overuse and misuse of antibiotics. There were a few slides that Dr. Majid also shared about inappropriate initial antibiotic therapy and the increase in hospital mortality. So this study showed that when the initial antibiotic or the empiric selection was inappropriate, meaning that it has poor or no in vitro activity against the organisms that were causing an infection, the mortality is high. Even after 48-72 hours, antibiotics were corrected according to the culture result, but the mortality remains high. So it means that you have to be right the very first time, especially in empiric antibiotics in critically ill patients. So in antibiotic stewardship, these are the 5 Ds that we define for appropriate antibiotic. The first D is the right drug with the right indication. The second D is the right dose. And the third D is the right route of delivery. The fourth D is de-escalation. And the fifth D is the right duration. And when we prescribe antibiotics, usually the regimens that we give, we can classify them as prophylactic, preemptive, empiric, and definitive. And prophylactic means to prevent an infection, and the classic example is surgical prophylaxis. Preemptive means that we abort an infection. For example, the classic example is transplant patients when they have CMV, in their blood. To abort an infection, preemptive antibiotics, antivirals are given. And the empiric, when the initial microorganism is not known, and to address the issue of infection, the antibiotics are selected. So this is called empiric regimen. And the definitive therapy is when the identification of the organism and its susceptibilities are known. And the most common area of antibiotic use or misuse is the empiric regimen, because at this time the identification and susceptibilities of the microorganisms are not known. In order to understand the optimal antibiotic approach, there are three key elements that we need to think about and their interaction. One is the pathogen, one is the drug, and one is the patient. So the interaction between pathogen and the patient, it causes an infection. And to treat an infection, a drug, antimicrobial, is given. So this drug can cause toxicity, can kill the microorganism. And the interaction between what the body does to the drug is called pharmacokinetics, and it includes absorption, distribution, elimination. And what does the drug do to the pathogen or the body? This is called pharmacodynamics. And while we treat infection, these pharmacodynamics involve the concentration of the drug at the site of infection and killing of the microorganisms. So in order to have an optimal approach, we need to have three factors, consider three factors. The first is the patient factors, pathogen factors, and the drug factors. So the patient-related factors, the four most important is the accurate diagnosis of bacterial infection. So when the patient first comes with fever or signs of infection, this could be because of viral infection, or sometimes non-infectious causes also mimic like a bacterial infection. So it's very important that you diagnose very accurately at this time. Misdiagnosis at this point will lead to misuse of antibiotics. The second point is that once diagnosed that the patient has a bacterial infection, but not all bacterial infections require treatment. For example, a patient who has a chronic osteomyelitis with an exposed bone, so treating with antibiotics will not cure this infection unless in a larger plan there is a plan to have a flap cover to cover the bare bone that will lead to the eradication of the infection. So after you establish the diagnosis of bacterial infection, a larger plan should be put in whether this patient needs antibiotics or no. Severity of infection and urgent need of antibiotics is very important, and classically we do see every day, in septic patients who present in our ICU. Antibiotic delay more than 1 hour after the episode of hypotension leads to 8% increase in 8% mortality every hour. So urgent need of antibiotics at the time is very important. So the first question that a prescriber should ask, is it really urgent to give antibiotics now? Is this patient going to survive till tomorrow? For example, a patient who comes with subacute bacterial endocarditis going on for like 2 months. So there is no urgency to throw antibiotics because this infection has been going on for 2 months unless there are red warning signs that require urgent antibiotic treatment. Third thing is allergies. As Dr. Noor also said, that there are many prescriptions being given to the patients without asking about allergies. And though the life-threatening allergies are not that common, but once it happens, the consequences are catastrophic. Renal and hepatic function to adjust the dosages and to prevent the adverse events of the drugs. Pregnancy and lactation considerations should be thought before prescribing antibiotics. And immunocompromised status. Immunocompromised patients usually, because of their decreased immunity, may be harboring more than, one infection. And the differential diagnosis of that infection could be broad because atypical organisms can also cause infection in these cases. For example, HIV patient who has, who may have pneumocystis pneumonia at the same time, he may have CMV retinitis at the same time, and he may have cryptococcal meningitis at the same time. So in these patients, usually empiric antibiotics are broad. And the third thing is source control. Sometimes we give antibiotics and the patient is not improving. So we think that the patient is resistant to antibiotics and the antibiotics wrongly get escalated. So if the source is not controlled, no matter what you do, antibiotics is not the answer. So if there is an infected line, you need to remove the line. If there is a urosepsis and there is obstruction, you need to remove the obstruction. And if there is undrained collection or pus, that needs to be drained. The pathogen-related factors, the site of infection and knowledge of common pathogens is very important because we know that the organism causing infection differ according to the site. For example, UTI is 90% caused by E. coli, while sore throat is mostly viral or streptococcal. Similarly, organisms for pneumonia are different for community-acquired, and the organisms are different for hospital-acquired infection. So the knowledge of these common pathogens is very important for that site of infection. Then establishing the likelihood of drug-resistant organisms is important because the antibiotic selection varies. And the questions to ask or to look for in the history to see what is the likelihood of drug-resistant organisms in this infection are exposure to the environment or antibiotics. For example, infections acquired in the hospital are more likely to be drug-resistant as compared with the community-acquired infections. And the patients who have been exposed to antibiotics are more likely to select out resistant bacteria than those patients who were not exposed. Adequate collection of culture specimens should be taken before antibiotics so that after 48 to 72 hours of timeout, we should have identification of the organism to help us de-escalate the therapy and narrow down the spectrum of our antibiotic regimen. Colonization versus infection, this differentiation is very important. And we do see that it's another area of most common abuse of antibiotics, especially asymptomatic bacteriuria get antibiotics very commonly. Similarly, these chronic wounds who are colonized, and they also get, it's an area of antibiotic abuse. Then there are drug-related factors like appropriate choice according to the likely organism or according to the culture results. Use of local data is very important because these organisms and their sensitivity pattern, they differ from one institution to other, one region to other. So knowing your local organism or local outbreaks and local pattern of sensitivities is very important. And use of guidelines, we do have international guidelines, but the local guidelines are more relevant, and if available, they should be consulted. And in NGHA, we just updated the local guidelines, and soon they will be updated on the intranet. And the best evidence regarding the efficacy and safety of antibiotics is the randomized or quality, research of efficacy, or the human studies. Adequate dosing is very important. Adequate route of delivery is important. In critically ill patients, even if you use those antibiotics with high bioavailability, still, because these patients require a good peak in a short time. So the critically ill patients still end up getting IV antibiotics because of that issue. Drug interactions are very important, as these interactions can increase the level of the drugs and can decrease the level of the drugs, making them ineffective. Antibiotic timeout at 48 to 72 hours is very important. And at this point, the thought process is to de-escalate or discontinue, but even escalation can be done. For example, if MRSA coverage is not given and the blood culture after 48, 72 hours grow MRSA, so antibiotics can be escalated to cover that organism, or de-escalated to discontinue the antibiotics that are covering gram-negative organisms. Bug-drug mismatch should be addressed at this point. Therapeutic drug level is important for those antibiotics with the narrow therapeutic index, that is a narrow range of drug levels for the toxicity as well as efficacy. And more commonly we do it for vancomycin and aminoglycosides. IV to oral switch, this is a very cost-saving intervention, and duration is very important. Now with the recent literatures, the trend is to go with shorter durations, and the pneumonia duration of antibiotic regimen in pneumonia is decreasing. Even for the hospital-acquired pneumonias, it has come down to 7 to 8 days. It should be evidence-based, and some laboratory tests like procalcitonin, discussed by Dr. Asim also, it can help in stopping the antibiotics or de-escalating the antibiotics. So if the procalcitonin is improved, 80% improvement, or becomes normalized, then that's the point that can help us in discontinuing antibiotics. The pharmacokinetic and pharmacodynamic principles are very important for some antibiotics in determining the optimal efficacy of these antibiotics. So in this slide, you can see in the red, we have antibiotics that kill the organism by time dependency. What does this mean? That there is a term we call MIC, which is minimal inhibitory concentration. That is the lowest level of antibiotics that can inhibit the growth of 90% of the organism surveyed. So beta-lactams, carbapenems, these are the most common antibiotics that kill according to the time dependency. That means that according to the time, the level of antibiotic is above MIC. So for example, if for carbapenems, the efficacy of carbapenem depends if the level of carbapenems remains above MIC for 40 to 50% of the duration of dosing interval. While for penicillin, it's 50%, and for cephalosporins, it's 60 to 70%. On the other hand, we have antibiotics that kill by the concentration dependency. What does that mean? That it depends, the efficacy depends on the concentration of the antibiotics above the MIC, and it doesn't depend on the time it remains above MIC. And the classic example for this is aminoglycosides, which are shown in the blue here. And on the right-hand side, this fluorescent green, these are antibiotics that have the killing efficacy according to they share the both characteristics. That is the concentration dependent as well as the time dependent. And the classic example are fluoroquinolones and vancomycin, the glycopeptides. So this slide shows this graph in fluorescent green. This is the area under the curve. So it means that it covers both the time dependency as well as the concentration dependency. The blue arrow, when we give antibiotics, so there is a peak of antibiotics. So the blue arrow shows the peak concentration at the peak of this arrow. So this is called Cmax. So the antibiotics that kill by concentration dependency, like aminoglycosides, so if you give in such a dose that they create a high peak, and even after that, even if their level is below MIC, they still are very effective. At the same time, the nephrotoxicity and ototoxicity of aminoglycoside is reduced, because in the intermittent dosing, the level of aminoglycosides to which the tissues are exposed is higher as compared to when you give a high dose, once a day. So this is called once a day dose regimen. Usually aminoglycosides or gentamicin is given 1 to 2 milligrams per kg every 8 hours. But when you give, according to this pharmacodynamic principle, you give 5 to 7 milligrams per kg one dose once a day. So this will create a very high concentration. This will increase the efficacy of the antibiotic as well as minimize the side effects of nephrotoxicity and ototoxicity. This red arrow horizontally above the MIC, which is this dotted line, this arrow shows the killing by the time dependency. And this is classically done by the beta-lactams. So in the next slide, I will show you how it kills, just to give an idea. So in this graph, you can see that this is the killing by maximum concentration over MIC. And the antibiotics that kill by this are tobramycin, which is an aminoglycoside, and ciprofloxacin, a fluoroquinolone. And compared with ticarcillin, which is a beta-lactam antibiotic that kills with the time dependency. So these colored lines, they show the MIC, the times MIC of the antibiotic. So the green line shows that this is 64 times above MIC, so concentration is very high, while the black one or the blue one, it shows only 1/4 of the MIC. On the y-axis, this is the reduction or increase in the colony forming units of the microorganisms incremented by log 10. And on the x-axis, we have time here. So what happens when you give antibiotic in an increasing concentration above the MIC? So when you increase the concentration of a drug, for example, tobramycin, so here you can see that this blue curve that shows the concentration is 4 times MIC. There is 2 log reduction from 6 to 4. But when you increase further, for example, this green line, which is 64 times the MIC, then the reduction is further 2 log reduction. So now you compare this with ticarcillin, which is beta-lactam antibiotic, that when you give 4 times in the concentration 4 times MIC, so the reduction is 1.5 log reduction. But when you increase further to 64 times, then the reduction is less as compared, or the killing is less as compared to the killing with the aminoglycosides. So this shows that aminoglycosides, when you increase the concentration, the killing efficacy is increased, while the beta-lactam antibiotics, it's not increased that much. In contrast, the beta-lactam antibiotics that kill according to the time dependency. So using this pharmacodynamic index, we can use to increase the efficacy by increasing the time that the concentration of antibiotics is above MIC. So now in this you can see that on the y-axis there is a probability of target attainment. So the 1 means 100% attainment, and on the x-axis you have the MICs. So with the MIC of 0.25 for Pseudomonas, you can see that if you give 500 milligram 8 hourly, the target or the killing is 100%. But when MIC increases to 4, for example, here, and you can see here that the probability of target attainment is only 35%. Now, by using this pharmacodynamic index, we can increase the efficacy of meropenem by just playing with the infusion. So if we increase the meropenem in this green circle, 1 gram 8 hourly, so this will increase the efficacy to almost like 70%. But there is another trick that we can do here to increase this efficacy further by allowing the antibiotic levels to remain above MIC for more duration of time. And this can be done by increasing the infusion time. Rather than giving in half hour, it can be given in extended time, for example, 3-hour infusion. And when we do this, what happens that the target attainment is almost close to 100%. So this is how these pharmacodynamic indices can be utilized for optimization of antibiotic regimens. And usually this is done for the critically ill patients or in hospital patients. So in summary, resistance is going to stay with us and no choice but to conserve antimicrobials and minimize spread of resistant organism. Remember the 5 Ds of appropriate antibiotic therapy: the right drug, the right dose, the appropriate route of delivery, the de-escalation, and evidence-based duration of therapy. Implement these basic principles of antibiotic therapy according to the patient, according to the microorganism and the antibiotic factors. And these PKPD indices can be used for optimization of antibiotic therapy. So this is my last slide, and this is the photograph, a poster made by a 17-year-old girl who won the WHO poster competition, showing that life without antibiotics is a happy life. So the future of antibiotic depends on all of us, and I'm going to conclude my talk here. Thank you for your attention, and if anybody wants to raise any questions or comments, the floor is open.
Thank you, Dr. Nazir. That was a really nice introduction to the tips and tricks section in this part of the symposium. I really like how you clearly went through the best way to approach antibiotic prescribing by, like, you broke it down, and also giving us a bit of overview about the best way, you know, pharmacokinetic, pharmacodynamic optimization of antimicrobial use. We will leave the question and answers to the end, if that's okay with you. Please, the audience, just make sure to send your questions through the Q&A part. For now, I would like to introduce Dr. Maher Al-Ahmadi. Dr. Maher is an infectious disease consultant, as well as training in infection control and antimicrobial stewardship. He works at National Guard Jeddah, and he is going to be talking to us about rapid diagnostic tests and antimicrobial stewardship outcomes. Thank you, Dr. Maher, for joining us today.
Thank you, Dr. Noor, for the introduction. Is my slide clear for everyone?
Yes, your slide is clear and your voice is clear.
Excellent. So my topic today about very important concept also in the antimicrobial stewardship, and we need to combine with antimicrobial stewardship, we will get the most benefit in optimization of the antimicrobial prescription. So the outline of my presentation, I'm gonna go through quick introduction and the consequence of delayed and inappropriate antimicrobial therapy on patient outcomes, and the need of rapid diagnostic tests, and what are the rapid diagnostic tests available right now, and which test, and what is the SB rule in guiding the best use of rapid diagnostic tests. So the key concept in the field of infectious disease is organism identification with subsequent antimicrobial susceptibility testing. So the optimization of therapy remains a challenge, especially when antimicrobial administration within the first few hours of sepsis recognition is critical. And also this was explained by Dr. Said in his presentation. This is the scary diagram that was released that estimate by 2050, the major cause of death will be antimicrobial resistant by 10 million deaths, even exceeding the number of the cancer death. So in the early initiation of antibiotic, Kumar and colleague demonstrated the critical nature of timely antibiotic administration in patients with septic shock. They found that each hour of delay over the first 6 hours resulting in 7.6% decrease in survival. And this study illustrates the importance of the concept of getting it right upfront. This is another study showing the impact of inappropriate empiric antimicrobial therapy on mortality of septic patients with bacteremia. It's a retrospective study, and they found patients with septic shock and inappropriate first dose of antimicrobial significantly had a higher 28-day mortality rate, 61% versus 41% with significant p-value. So what are the standard methods? The routine, the traditional method in lab, in microbiology lab. So the standard technique for identification of organisms are based on phenotypic method, which requiring 48 to 72 hours to provide a final result, compared with a rapid diagnostic test, which provide the final result within hours of the growth. So this is the concept of the rapid diagnostic test. You're gonna get a faster result. So the rapid diagnostic test tests a wide range of pathogens causing bloodstream infection, respiratory tract infection, gastrointestinal infection, CNS infection, and also can give you a hint about antimicrobial resistant pathogen. So this is what's called also syndromic screening, and can distinguish between viral versus bacterial infection. So RDT, as an advantage for RDT, it can decrease the time to identification of pathogen from days to hours. That lead to facilitate the decision about whether or not to prescribe antibiotic from the beginning. For example, this patient has flu, why I need to start antibiotic. Also, it prevents the use of unnecessary antibiotic. For example, this patient was on septic shock and you start broad spectrum antibiotic of meropenem and vancomycin, and you can get a result within like the next day that this patient has an E. coli, why I need to continue on vancomycin. So also prevent or facilitate the de-escalation, very important concept in the antimicrobial stewardship. When you know that this patient has a band-sensitive, this is a band-sensitive organism, why I need to continue on broad-spectrum antibiotic? This is to facilitate the de-escalation. Also, decrease the antimicrobial resistance spread. Very important concept in infection control. When you know this patient by screening from the emergency that this patient has a CRE, it allows me directly to isolate this patient and apply contact precaution rather than to keep him in a shared room and distribute all these CRE to all the other patients. So in RDT, few studies have demonstrated the benefit by enabling the timely antimicrobial optimization, which is in turn may lead to decreased mortality, shortens the hospital stay, and lower hospitalization cost. The rapid diagnostic tests are considered the game changer. So this is the benefit from antimicrobial, as I mentioned before. It can optimize antimicrobial use, minimize unnecessary antimicrobial use, decrease C. diff rate, and also reduce antimicrobial related adverse drug events. What are the disadvantages for RDT? It's very expensive. Few studies of cost effectiveness, and there are few implementation strategies to maximize their value. There is a risk of contamination, especially when you are dealing with a genetic material, with a molecular-based studies. Need DNA, RNA-free area. Cannot indicate the viability of the pathogen detected. And the most famous example that it's COVID-19. When you detect COVID-19 after 3 weeks from PCR-based test, is it a viable virus or it's only a dead particle pathogen? So here cannot this indicate the viability of the pathogen detected. So I'm going to focus here about the implementing of the antibiotic stewardship, the guideline that released by IDSA and SHE that related to RDT, rapid diagnostic test implementation with antimicrobial stewardship. There are two recommendations regarding the RDT. The first recommendation, we suggest rapid diagnostic tests in addition to conventional culture and routine reporting on blood specimen. And you can put 100 line about if combined with the active antimicrobial stewardship support and interpretation. So this nice diagram show you, let's say from the beginning, on the left side, the patient has a fever and now you are draw blood because you want to do a septic screen, blood culture. So, and then the blood culture bottle will be kept in the incubation machine, which is Bactec. And then this machine will alarm that there is a positive bottle. And then the first step that will be done by microbiology technician, it's a gram stain. So they will take from this bottle and they will see the gram stain. And the first step that will be done by microbiology at this time, that they did a gram stain and then they will call a lab. They will call, for example, Ward 16 or ICU. Sir, you have a gram positive cocci in cluster, or you have a gram negative bacilli, and that's it. And then he will apply the positive blood culture on blood agar, McConkey chocolate agar, and he will be kept it in the incubation down. Then he will look for it after 24 hours. Then the colony will appear, and then they will do the pathogen ID through API, and then another 48 hours for susceptibility. While the concept of the RDT, after the technician done the gram stain, he will apply to the, for example, to the PCR or biofile or any rapid diagnostic test, and you will get directly the pathogen ID. So within 1 hour after gram stain, you will call and you will inform that this patient has a Pseudomonas in the blood. This patient has Staph aureus in the blood. Very important. It will cut the time from 72 hours to 1 hour. This is again another diagram also about the impact of the rapid diagnostic testing in optimization of antimicrobial selection. You can see here from the positive blood culture, and you apply PCR, you will get the result within an hour, rather than to wait for 24 hours to get a culture and then another 48 to 96 hours to get a final culture and susceptibility report to the doctors with a routine and standard culture, standard microbiology practice. It tests a wide range of pathogen. For example, this is what's called PCR or biofire film array that can detect from the positive blood culture up to 28 pathogen. It can detect many gram-positive bacteria, many gram-negative. It also can detect yeast. Within 1 hour, you will get a call that this patient has a Candida crocea in the blood. Also, it can detect antibiotic resistant, MIC-A for methicillin resistant, FAN-A, B for PRE, and also for KBC. So only it has a limited resistant gene with this kind of test. Also, there are a most common resistant gene can be detected by other machine like MIC-A, MIC-C for MRSA, FAN-A, FAN-B for glycopeptide, ESBL, also for TB, one of the important pathogen. For example, you can get by doing gene expert on the sample that this patient has a resistant to rifampicin by detecting RBOP gene within hours, rather than to wait 56 days to wait for the culture susceptibility. So it's cutting it short. Also, another gene, which is INHA and KHG gene, which is detecting the mutation in isoniazide, allow you to start to avoid, for example, rifampin and isoniazide if the patient has resistant from the beginning, rather than to keep this patient on anti-TB, useless anti-TB, for 56 days awaiting the routine culture susceptibility. Also, CRE, one of the struggling organisms that affecting not even our institution, but all our kingdom. You can see we have here a rapid test that can detect the CRE gene, which is the most common here in our Middle East, which is the OXA48, but also can detect KBC, which is more common in US, NDM. We seeing here also some strain of NDM, VIM, and also IMB. So limitation is limited and predetermined organism. RDT available, I'm going to focus here about what's available in the National Guard. We have the film array, biofire, turnaround time within 60 minutes, and also we have the MALDI-TOF. You hear about MALDI-TOF. So MALDI-TOF is a matrix-assisted laser desorption ionization time of light. The MALDI-TOF only can detect the ID pathogen, so it can give you Pseudomonas, but it cannot give you the resistant markers on that Pseudomonas. And the turnaround time also, it can give you within 10 to 30 minutes if you get it directly from the colony. This table showing the difference between the turnaround time and the cost and the skilled personnel for these rapid diagnostic tests. You can see here in the real-time PCR, it's very costly. It can cost 500 riyals Saudi per one test of, for example, multiplex PCR for respiratory panel. So RDT for bloodstream infection, faster time to give you faster time to organism identification and to information on resistance. This allows clinicians to target antimicrobial therapy in more rapid manner, and also which can translate into improved clinical outcomes. The limitation, every test has a limitation. Its inability to analyze polymicrobial culture if you have more than organism in the blood, and little of assay capable of detecting resistant in gram-negative. Sometimes only limited, only KBC. I don't have an issue in KBC with KBC in for example, in our institution. Mainly, I have issue with OXA48. So this is one of the limitation that only that I can detect it with a CARBA-R test. Proper implementation is a labor and resource intensive. You need a molecular free space in the microbiology. The use in the absence of active ASP intervention has not been shown to improve antimicrobial use. And guideline, as I mentioned in the IDSA and many studies, specifically recommend the use of the RDT for BCI bloodstream infection only if paired with active antimicrobial stewardship support and interpretation to the providers. Let's move to the, yes?
Yeah, sorry, 5 more minutes.
Okay, so let's move to the rapid viral testing. So here also we suggest the use of the rapid viral testing for respiratory pathogen to reduce the use of inappropriate antibiotic. This is the classical part and the currently part. We have the PCR for influenza, COVID-19, MERS-CoV, multiplex respiratory panel again, which is a syndromic screening. It can detect more than 20 pathogens with sensitivity more than 90%. This is an example of the organism that can be detected by RDT, the most common cause for upper respiratory tract infection, plus bacteria. But here you can see here, if we apply this patient for a pneumonia patient, the most common organism for pneumonia, which is strep pneumoniae, is not there. And the most common also organism for hospital-acquired pneumonia, like Pseudomonas, is also not there. So RDT for respiratory infection, data specific with the ASP largely absent. One randomized trial and observation data that published in Lancet, they saw the impact limited only to patients with the influenza positive result. Found that there is association with lower odds of admission, length of stay, duration of antibiotic, and number of imaging that in the studies obtained. Detection of other virus, very important. If I detect that this patient had admitted to the ICU with respiratory failure and the multiplex PCR showing it's rhinovirus, is this will hold antibiotic? This is the most important concept. So detection of other viruses did not change the clinical management, including use of antibiotic. Also, there is a limitation, as I mentioned, for respiratory panel, reduction in unnecessary antibiotic use not being observed across study when detecting virus other than influenza. Again, the main limitation of current respiratory molecular panel is lack of bacterial target for community and hospital-acquired pneumonia. By the way, there is what I heard from my colleague in microbiology, there is a new panel that allow us to detect the most common organism like strep pneumoniae and Pseudomonas and other organisms. So ASP, important role in guiding the best use of RDT, improving the patient clinical outcomes and minimizing unintended consequence of antimicrobial misuse. This is the RDT and the core element for antimicrobial stewardship from the CDC. You need the leadership support, accountability by physician. This is only related to the rapid diagnostic test. I'm gonna go quick about, you can see it quickly. So you need a financial support for RDT. You need RDT into clinical practice. You need to introduce the test with a help of antimicrobial stewardship. After that, you need to do tracking and monitoring. Is this RDT allow me to, for example, cutting broad spectrum antibiotic? You need to have a metrics measures for implementation of the RDT. This RDT also provides a collaborative opportunity for ASP to work with administration, physician, and microbiology laboratory personnel. And ASP should have active role in implementation and incorporation of the rapid diagnostic test. You need to have a full algorithm and also to introduce it with the use of the rapid diagnostic test. If you want to take home message from my presentation, you can take home this slide as a take-home message from my presentation. Whenever antimicrobial stewardship working together with the rapid diagnostic test, you will have the full effectiveness. This study, I'm going to go quick about the important studies that shows the effective of ASP when combined with RDT. This study showing the ASP among with using of the PCR in Staph aureus bacteremia, they found that with antimicrobial stewardship, switch from empiric vancomycin to cefazolin or nefacillin was like 1.7 days shorter, both using RPCR, which is the rapid diagnostic test. Also was significant for length of stay was 6 days. Was sorry, for the mean hospital cost was significant, was 0.02%. But when we came to length of stay, although 6.2 days was shorter, but was not significant p-value. This is another study showing the multiplex PCR from the positive blood culture. They have 3 arms. which is the control arms without they do conventional microbiology lab, while here the second one, multiplex PCR with the comments in the microbiology report, and the third arm, which is multiplex PCR with a comment in micro report, but with a real-time feedback by antimicrobial stewardship. You can see here the most important thing for time to de-escalation that was very significant with antimicrobial stewardship by 21 hours and with significant p-value. Also here was significant in decreasing broad spectrum antimicrobial with no significant p-value. Here also there was no difference in the decrease in the length of stay, mortality and cost among all the three arms. But when it came to test cost, was significant for the conventional one, the routine one. This is the meta-analysis that include 31 study with 5,920 patients with bloodstream infection and the use of molecular rapid diagnostic test, which is mainly MALDI-TOF, PCR, PNFH. And I'm gonna go quickly here. You can see here, whenever the RDT was combined with antimicrobial stewardship, odds ratio was less than 1 for that. While here in the RDT without ASB, still it's although it's toward the less than 1, but it's crossing the line. Here also, which organism has a benefit from the RDT, you can see here gram-negative organism was significantly with the use of the ASB in favor of the RDT, and the total one is favoring of the rapid diagnostic test. So in summary, significant advance with the newer technology have been made in microbiology rapid diagnostic for BCI. By the way, there is also many rapid diagnostic tests for CNS, for gastrointestinal. The time is limited here, I cannot go through it. This allowing for sensitive testing for multiple organisms at the same time. So the take-home message from my presentation, partnership between clinical microbiology lab and antimicrobial stewardship is increasingly important. And new and more complicated tests and novel diagnostic approach become available. And bloodstream infection, ASB intervention required for clinical impact of RDT. In other infection need more research. And all of these associated with improvement of patient care. Thank you so much. I am on time.
Thank you, Dr. Maher. I think your presentation takes us to the next level of stewardship, how to find a way to utilize the resources that we have, the technology that we have to try to move forward with improving patient care and linking it with stewardship. So thank you for that. Now we will move to our last but not least, a presentation by Dr. Henry Bafobani. Dr. Henry is an infectious disease consultant within the infection control department here in National Guard Riyadh. He is unknowingly a cornerstone of stewardship here in general because of his way of discussing patients and giving cases, and this is why his talk is about, he will be giving a couple of case studies in antimicrobial stewardship. I hope, I know we have gone over time. I hope you can join us and stay with Dr. Henry's talk and leave a couple of questions till the end. Dr. Henry, the floor is yours.
No, can you hear me now?
Yes, I can hear you clearly and I can see your slides.
Oh, excellent, excellent. Yeah, good afternoon, everyone. I'm just going to go through about 3 cases, basically to highlight certain salient points in stewardship. The first 2 cases basically are drawn from the WHO website, where they have modules in stewardship on disease states like lower respiratory tract infection, community-acquired pneumonia, surgical prophylaxis, and all that stuff. So I picked 2 of them and I'll go through them sequentially with, you know, in the normal setting, this is an interactive talk, but because of COVID, we have to find innovative ways of delivering this. So I'm going to start off by, oh my God, how do I move forward? Next. Okay, so basically the objective is to highlight antibiotic stewardship principles through real case presentations. The first case, we have a 25-year-old female with a splenectomy, which by itself renders the patient as an immunocompromised individual, presented disoriented, febrile, tachycardic, hypotensive, with a respiratory rate of 28 breaths per minute, and obviously hypoxic. And it's also noted that she has pleuritic chest pain. So obviously we know some mnemonic processes going on. Now, the way these models are set up is we go through a clinical assessment, which includes a diagnostic workup. You have to make a therapeutic decision in the initial assessment, and then, if possible, patient or family education. Then subsequently, you need to reevaluate the patient. It is at this time that hopefully you will have some results of your initial assessment back, and you review the data and you use that data to modify your antimicrobials. This is the conventional way by which patient evaluation goes: initial assessment and subsequent evaluation, and modifying antibiotics. The goal of stewardship, or at least the stated goal of stewardship, is through this process you are guided in judicious use of antimicrobials. In other words, your empiric choice is justified to some extent, and if you do have to do empiric antibiotic use in the subsequent evaluation, you are guided by data to make the right decision to modify the antimicrobials, which may include discontinuation or de-escalation, or at least sometimes maintenance of the initial regimen. So the diagnostics, in such a patient, obtaining the blood cultures are very essential. And obviously I should add, if there's sputum production, sputum cultures also. Now, these are very important because in the subsequent evaluation, they prevent the continuation of unnecessary broad spectrum antibiotics, which leads to increased cost and obviously resistance, as we all know. So and also in doing this, you have to be careful. And I'm going to talk a little bit about the technique of obtaining the blood culture so as not to lead to contamination, which in by itself can lead to unnecessary antibiotic use and increased cost. Okay, so obviously you need to identify the patient and then, you know, do the necessary paperwork and get the bottles ready and all that stuff. Hand hygiene is very important, and this has to be emphasized to the nurses who are, you know, watching this and listening to me. Hand hygiene, to prepare the bottles, prepare the skin site, collect the samples, and inoculate the bottles. This is very important. And also the volume of blood you need. If you're an adult, you need a minimum of 20 ml. That means 10 ml each in the anaerobic and aerobic bottles. Now, this is important because there have been very rare instances when patients are asthmatics and they will get like 10 ml and divide them in two, and each bottle will have 5 ml, and it will be inadequate for processing in the lab and can lead to non-detection of infection. So it's very important for healthcare providers to be aware of the minimum requirements of blood for the aerobic and anaerobic bottles. Now, we should avoid routine surveillance cultures. Now, whenever a patient has an indwelling catheter, it is also recommended that you get a sample from the intravascular line as well as the from a peripheral site. And this has significance in ruling out a line-related infection in the future. It's also best to have a dedicated staff to perform cultures. In other words, and this is a nursing issue, that on the floor, if there are dedicated staff so that there's uniformity in the technique, that leads to decreased errors, okay? Now, in the case that I just presented, it offers an opportunity for the institution to study their guidelines for empiric treatment. Now, I will mention that guidelines vary from institution to institution, and the guidelines are generated by the cumulative antibiograms, you know, something to reflect the community, okay? So whenever you have a case like this and you are going to make empiric antibiotic choices, you are, you know, you have at your disposal the local antibiogram, which basically impacts the selection of the empiric treatment based on the guidelines available to you or not, okay? So then therapeutic decisions. Now we obviously have a primary pulmonary case leading to what is probably a bloodstream infection, okay? The severity we know. Whether this patient is admitted or not depends on certain criteria, which I'll go through in a minute, okay? Now, we are assuming this patient is coming from the community, so the drug resistance, according to this WHO slide, is labeling it as low, but it could very well be medium to high risk depending on the locale by which you are practicing. It is not unknown for patients who come from the community with very resistant pathogens, but for purposes of this lecture, we are assuming this is low. And the patient factor here is she is splenectomized, which renders her susceptible to infection with encapsulated organisms. And we obtain blood and sputum cultures. Basically, this is the data that we have. So with this, we have a decision to make. Or like I said, this was meant to be an interactive session, but because we cannot do that, we have to find innovative ways. So basically, ceftriaxone and azithromycin for this patient is not unreasonable as an empiric choice. Having said that, you know, there are other modalities, there are other choices which probably will, you know, not be inappropriate, like using moxifloxacin or whatever. But the idea here is not to get overly broad by using agents like meropenem, carbapenems and stuff, okay? Obviously, depending on the presentation, I've heard a lot of doctors tell me that, you know, the patient had ESBL infection in the past, within the last few months, so then they feel they are justified in using a carbapenem when such a patient presents. You know, it is best to deal with these patients on a case-by-case basis during prospective audit rounds. But for purposes of this lecture, I think ceftriaxone and azithromycin will suffice, okay? When the patient improves, then you are faced with the challenge of getting an oral agent, okay? It's much simpler if you have a pathogen and you can select your oral agent according to the pathogen. Here it's stated amoxicillin, but I will mention that, you know, it could be Bactrim, it could be a quinolone, could be Augmentin, but the idea is an IV to PO switch as soon as possible when the patient is able to tolerate PO and there's documented improvement based on clinical assessment and data review. The importance of IV to PO switch cannot be overemphasized. Okay, and interpretation of the blood culture results is also very important to know what is a contaminant and what is not. And also, you know, for example, if somebody has been on antibiotics for a very long time and there's some yeast found in the sputum culture, it stands to reason that you are probably dealing with an overgrowth syndrome and not true invasive fungal infection. Okay. Okay, now let me just go on to the I have to run through these slides because I have 2 more cases and time is limited. Okay, I have some repetition. Okay, now let's go to the second case. The second case basically introduces the concept of a lower respiratory tract infection. We all know that this is a very challenging situation because the vast majority of these infections, or a significant majority, are caused by viruses. And this condition probably elicits the most inappropriate prescription of antimicrobials, especially in prescribers in the outpatient setting. And so knowing when to suspect viruses versus bacteria is very important. Okay, now community-acquired pneumonia is basically can be listed under respiratory tract infections in the lower zones. And that one basically is a leading cause of morbidity and mortality, especially in the elderly and children. Okay, but we do know that most of lower respiratory tract infections are viral infections and are self-limited, and antibiotics are not needed. So the challenge is how to weave through this so as not to give antibiotics inappropriately. Now, the first case here, we have a 45-year-old female with a 2-day history of a fever, cough, and pleurisy. Rusty brown sputum. The patient is not up to date on her vaccinations. She's very febrile, tachypneic, and tachycardic, and hypoxic on room air, and has bilateral rales and egophony. Now, from this, it stands to reason that the patient very likely has a pneumonic process going on. But the question is, are we dealing with the virus or are we dealing with bacteria? And how will the information you harness the very time you see the patient influence your choice of antibiotics? And also, how will the subsequent information influence modification of your antimicrobials, be it de-escalation or discontinuance? Okay, so the patient now, we know, systematically evaluating the patient has fever, chills, cough, sputum production, and the point we have even been told the nature of the sputum being rusty sputum, which points to bacteria. Okay, now I should mention that some viruses can give you greenish sputum and all that stuff, but it's not that common, especially viruses that can cause a small degree of pulmonary hemorrhage when you have hemosiderin leading macrophages in the sputum. It can have the appearance of rusty sputum, but by and large, rusty sputum is something which people most conveniently associate with bacterial infection. The patient is tachypneic, and there's chest pain, which basically indicates involvement of the parietal pleura in the pneumonic process. But still, we don't know whether we are dealing with a virus or bacteria, okay? And I would wager that most people will probably start empiric antibiotics in this patient, but let's go on. Now, on exam, we have rales and crackles, rhonchi, wheezes, egophony. Egophony is more associated, egophony and dullness more associated with bacterial infection. Now, at this juncture, you know, the talk, by the way, no, how many minutes do I have?
You have, let's say, 8 or 10 more minutes.
Oh, are you kidding me? Okay. Anyway, egophony and dullness is more associated with bacterial infection. If there was time, I will talk a lot about, you know, basically the disappearance of the physical exam, that we doctors, we just don't examine patients anymore, okay? And there's a lot you could harness from a physical examination, which can lead to appropriate choice of antibiotics, okay? Now, here are possible pathogens in this patient, okay? Viruses and bacteria, okay? But as mentioned, based on the information we have harnessed, we suspect bacterial community-acquired pneumonia. So then what do? Okay, obviously you want to start antibiotics and you're going to be guided by your antibiogram. You're going to be guided by, you know, your community trends. And here we have IDSA guidelines, which is outdated. This is the WHO slide. So, but like I said, you refer mainly to your local guidelines. The National Guard has its own guidelines that you can refer to in a situation like this for antibiotic choices, okay? Ceftriaxone and azithromycin is not unreasonable. Having said that, there may be extenuating circumstances like allergy to beta-lactams and all that other things that may dictate the selection of a quinolone or even a carbapenem, which is very much discouraged. But by and large, the selection of initial antibiotics should be guided by institutional guidelines and, you know, other extraneous factors. Okay. In this case, a chest X-ray confirms left lower lobe consolidation. So the subsequent evaluation, let's see what happens. Are you going to admit the patient? The decision to admit the patient also is dependent upon certain factors. Is the patient confused? Is there renal insufficiency? Is there tachypnea above 30 breaths per minute? Is the patient above 65? Having said that, this is the CURB 65 criteria. There are other criteria that people follow, but basically this is a clinical decision, okay? If the patient has very good home environment, you don't have to admit every patient with pneumonia, no. You don't have to. And there are times that you admit patients who don't typically meet admission criteria, but all that depends on the patient, the physician's clinical gumption and how, for all intents and purposes, if the patient is hypotensive, elderly, tachypnic, above 30 breaths per minute, all these point to possible admission for this patient. Okay, so this patient was admitted, and then we had strep pneumo, and the decision to select an antimicrobial for this patient will be dependent upon local, you know, factors, susceptibility patterns, and whether the patient has been on antimicrobial use in the past. One thing I realize here is a lot of the patients that we see during prospective audit, they have had some contact with the healthcare system. So the prescribing physician initially will pick something which will cover nosocomial pathogens. And that cannot be, you know, that cannot be inappropriate. Sometimes, you know, there's justification for doing so. Okay. Okay, I have to rush through this because my time is limited. Now, the last case is basically something which I'll quickly go through, which involves a common problem that we face. Here we have a father who brings in his 11-year-old son to your office and states that he has had fever, a non-productive cough, a running nose, sore throat, and nasal congestion for 2 days. 5 of the child's friends have had similar symptoms in the past 2 weeks. All of them have recovered. On exam, the child's throat is erythematous, but there's no exudate. The conjunctiva are injected. The chest X-ray is normal. There's very mild leukocytosis with a mild differential. But guess what? The father is demanding a prescription for an antibiotic. This is not an uncommon practice where patients demand an antibiotic. So what should the physician do? I hope this was interactive so I could hear people's opinion, but I'll give this. Should you prescribe Zithromax? Should you admit the patient? Should you reassure the patient and the family that this is likely a self-limited viral infection and no antimicrobials are indicated? I think that's reasonable. Should you test the son and father for COVID-19? Now, we are living in different times. I don't think this is unreasonable. I think it should be something which should be offered to the father and son in such a scenario. And then there's a concept is, do you offer a delayed antibiotic prescription? And this is the gist of this talk, that the concept of a delayed antibiotic, it's very much used in Europe. It's part of the National Health Service system in the UK, and the Scandinavian countries use it a lot. And the concept is, the delayed prescribing of antibiotics for respiratory tract infection is the technique that can be used by the healthcare provider to reduce unnecessary antibiotic use in primary care. The prescription is issued by a healthcare provider for use by the patient at a later date if their symptoms do not improve. In other words, you know this is very likely a viral infection. You don't believe the patient needs antibiotics, but there's pressure to write an antibiotic. In this setting, it will not be unreasonable to give a delayed antibiotic response. And no, I would like your comments on this when I finish. Now, there's a Cochrane review which evaluated 11 trials with over 3,000 participants and investigated the effect of delayed antibiotics compared with immediate prescription or no antibiotics for patients with respiratory tract infections. All patients were included in the study, regardless of whether antibiotics were given or not. And they assessed for antibiotic usage, patient satisfaction, and reconsultation. Now, what they found, I think, is interesting. The patient satisfaction was similar for those who accepted delayed prescriptions. In other words, those who came in and the doctor did not think they need immediate antibiotics but gave them a delayed prescription. 86% were satisfied with that. They didn't cast the doctor out and leave. And those who had immediate antibiotics, obviously, they are happy, 91%. In the no antibiotics groups, only 82% were satisfied, leaving 18% unsatisfied. You know, this is the challenge of trying to convince patients that they do not need antibiotics. You are going to have some unsatisfied people. Now, antibiotic use was greatest in the immediate antibiotic use group. That's very clear, obvious. And interestingly, 31% of those given delayed antibiotics eventually ended up filling it. Now, this is important, which means 69% did not fill the antibiotic, did not fill the prescription, okay? And those with no antibiotics, you didn't give it to them, 14% of them managed to get it anyway. I'm sure they went to someplace else. Now, this is important because the concept of delayed prescription may have some use in managing patients with, who present and are deemed to have infections of viral etiology, but there's some form of pressure from the family to give an antibiotic. It may not be unreasonable to employ this technique of delayed delayed prescription. Okay, that's the end of my talk because the time is limited and I invite questions.
Thank you, Dr. Henry. That was a really, I know the cases because we've been discussing them. We see them every day. I hope the audience enjoyed them as well. I especially think that the last case you mentioned, the delayed antibiotic prescription case, is really an interesting topic that even Dr. Dua Al-Jifri mentioned in her talk. And I think it's really very useful, especially I hope we have some family physicians, even patients in the audience. If you find that this approach works for you, maybe perhaps read more about it, or you can contact Dr. Henry for more information. I have a few questions here that I'd like to address. There is one question, Dr. Henry, perhaps.
Yeah.
This is a question that was in the queue for a while, but I'll address it to you. In your opinion, what is the main role of infection prevention team inside hospital in antimicrobial stewardship?
The infection prevention team?
Yeah,
okay.
Infection prevention and control, yeah.
Okay. You know, about 2 years ago, I think 3 years ago, I remember there was one of the meetings that we had, which pre-COVID, the motto of the meeting was "It's all in your hands." That was the motto of the meeting.
Mm-hmm.
It's almost impossible to separate proper infection control practice from stewardship. Okay. Now, we all know that the simple act of hand washing has the power or capability of reducing infections by a significant number. You can tell me, no, I forgot what the exact number is, but it's some horrendous number that just by washing your hands. So the importance of infection control practitioners on the ground in the hospital cannot be overemphasized. I think it's extremely important, especially in the setting of education on appropriate hand hygiene, surveillance, and also supervising adherence to all the bundles, the community-acquired pneumonia bundle and all those. So their presence is almost indispensable, in my opinion.
Mm-hmm. And I find, if I may add, I find that communicating as a stewardship team with the infection control practitioners on a daily basis is really helpful. They identify trends in resistance in those wards or changes in practice, or they may identify, right, there's a new batch of nurses that have come in, perhaps you need to discuss this, or a physician has a tendency to do this, to have this practice. And I think this is why being a multidisciplinary team really helps. In addition to the general approach of antimicrobial of infection control within their general work expectation, I mean.
Sure.
The next question is for Dr. Maher, if he is around.
Yes, with you.
All right, great. Dr. Maher, there is a really nice question here. What about the sensitivity of rapid diagnostic tests? I think you mentioned that in your talk, but maybe you can briefly just highlight a useful answer. And in the case of combining rapid and routine tests, the cost will be doubled. I think the person who's asking has a concern. Should you combine rapid and routine costs? When would it be justified from a cost perspective?
Sure, it's an excellent question. So regarding the first part about the sensitivity, the rapid diagnostic test, maybe one of the slides I forgot to mention that there is what's called the antigen-based test, and there is a PCR test. So usually the PCR test has a higher sensitivity, and we can depend on it for more than an investigation, especially influenza, more than the viral diseases, and also even in the for bacteria like CRE and like other resistant organisms for MRSA. So regarding the second part of your question, it's really an excellent question about why I need to combine both. It will be cost more. Yes, I agree with you. There is a little study showing the cost effectiveness of this new RDT, but still some of the RDT cannot detect the sensitivity, for example. So that's why we need to do the routine culture to continue. And I think most of our lab now, they do that to get the susceptibility final, because PCR does not give you the final susceptibility. It can tell you that this is the gene that could carry resistant, but it cannot give you the final susceptibility for all antimicrobial. On the other hand, let's talk on the other hand. So we mentioned about combined, like the rapid diagnostic test with a conventional one. How about if I apply the rapid diagnostic, save more broad spectrum antibiotic on the other hand. So also on the other hand, I will be cost saving on that part, and maybe I will decrease the total like hospital stay, the total length of stay, the total hospital cost, and even the most important concept, which is the patient safety.
Absolutely. Nice. Great. So that was a very interesting reply as well. I hope you benefited from that. There are two more questions here. There is a question here for Dr. Henry. How can I protect myself and my family from antibiotic resistance?
Is this from, can you hear me?
Yes, we can hear you.
Okay, this is from a healthcare provider or from...
I'm not sure, but I think...
Okay, but well, let me give the general response. Number one, you know, when you are prescribed antibiotics, you take it to completion. There's a very common misconception that when I get well after the second or third dose, the remaining days are mafia. I'm not going to take them, okay? I think that is very important if the person asking the question is from the community. And also, do not share antibiotics. This is very common. I had it in my family. That when somebody gets sick, oh, there's some leftover here, give it to the person. You don't do that. You need to seek medical attention. And when you are in the hospital, if there's a healthcare provider asking this, you can contribute enormously to spreading resistance by washing your hands and following protocols. The simple act of washing your hands in between patients is extremely important, and not following laid down protocols like, you know, changing gowns, wearing masks and all that stuff. By doing that, I think you can do your part to spread resistance. And also, if you're a nurse asking the question and you are asked to obtain a urine culture, a urine sample from a patient, you do it correctly by, if you are not sure, you ask, but you just don't get it from the bag. You need to know the proper technique of obtaining a sputum culture from a patient. When you do all these things according to protocol and rightly, you are indirectly, and actually I should say directly, contributing to halting the spread of resistance.
Great. All right, thank you. So I have two quick questions that were addressed to me. The first one was, how would an ASP clinical pharmacist manage restricted antibiotics alone if there is no ID consultant or specialist on board? To whoever asked that question, I will just emphasize that pharmacists and clinical pharmacists do not have prescriptive authority. That means that we can neither prescribe nor discontinue medications. However, if there is a collaborative agreement that is clear, which means there needs to be a policy with clear recommendations on when a decision will be made and what the decision will be depending on the situation. For that to be the case, you have to really have a well-built antimicrobial guideline for your facility, and you also have to have a policy that determines who can make that decision. And in addition, I would also, of course, recommend that the person making those decisions, the ASP clinical pharmacist, have recurring discussions and trainings with someone who, because the main limitation for us is diagnosis, and prescribing and discontinuing medications is all about diagnosis. Whereas for us, our specialty is, we are pharmacotherapy specialists. This is my perception. I know there are debates on this, but this is my take on this. So I would really recommend that if there is no ID consultant in your facility, to bring in a practitioner, a physician who is interested in infectious diseases. This is how you can adjust things. The last question that was brought up was, when would we use prolonged infusion, and should it be used empirically for everybody? The answer is, I think because the question was, do I think that we should use prolonged infusion for everybody? I would say yes, not for everybody, but in certain situations with prolonged infusion, it would be good to decide based on your facility, based on your MICs, based on your patient population and your resistance pattern, which medications would be used empirically as prolonged infusion, and where you wouldn't even have to wait for pharmacodynamic optimization. So for example, in the future, in our facility, it needs a lot of discussion. We may consider using prolonged infusion, for example, for all patients admitted empirically, admitted with sepsis who are obese, for example. This could be one way to approach this. There's a lot of data on this. So if you would like more discussion, please email me. For the purposes of our talk today, I want to thank all the speakers and all the organizers and assistants who have made this event possible and the attendees. Please contact us if you have any questions or concern about the CME credit. And Dr. Bahir, Dr. Henry, and maybe the other speakers who are there, if you have any last comments, and then we can close.
I would like to thank you all, Sarah. It was a wonderful symposium, and thank you for everyone. I wish that all the audience was enjoyed.
Thank you. And I'm sorry, I just realized Dr. Nazir is within the speaker's back. Sorry, Dr. Nazir, I answered one of your questions. I hope that's okay. But in any case, everybody have a nice day, inshallah, and thank you.